Today we will focus on a very important topic in head and neck oncology. We will discuss how to manage early glottic cancer using surgery. Specifically, we will talk about transoral laser microsurgery, or simply TLM. In my earlier videos, we discussed laryngeal and hypopharyngeal cancers in great detail. We also did a separate video on great debate of TLM versus radiotherapy for early glottic cancer. If you have missed it, please go back and watch it. It explains the survival rates and the pros and cons of both options. Today, however, our focus is completely on the surgery. We will learn everything about transoral laser microsurgery, or simply TLM, as a treatment modality for early laryngeal cancer. Here is the exact roadmap for today's lecture. We will cover this vast subject in these 8 subheadings. First, we will look at the anatomy and microvasculature of the larynx. You cannot safely operate if you do not understand these hidden structures. Second, we will discuss pre-operative triage and surgical barriers. We will learn how to use the laryngoscope to select the right patient in your clinic. Third, we will study the laser machine itself. We will understand the principles of laser biophysics, dosimetry and hardware. Fourth, I will show you European Laryngological Society classifications. You must know these ELS cordectomy types perfectly to plan your surgery. Fifth, we will tackle the most stressful part of our job. We will discuss margin assessment and pathological dilemmas. You will learn exactly what to do when you get false positive reports caused by the laser. Sixth, we will look at what all are the barriers of TLM. Seventh, we will focus on the patient's functional recovery. We will outline the strict protocol for post-operative care and surveillance. Finally, we will look at the future of our field. We will explore exciting advancements in TLM, including artificial intelligence and robotics. Let us begin. Hello friends. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi for over 12 years. I have been practicing and teaching oncology for more than a decade. I did my MBBS and post-graduation from CMC Vellore. Then I did my DNB at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. I pursued a fellowship at the Royal Marsden Hospital in London and have later undergone specialized training from the United States. I have published almost 85 research articles and abstracts in PubMed Index international journals. Before we start our first topic, let us define our basic terms. What exactly does transoral laser microsurgery mean? We can break this down into 3 simple words. First is transoral. This means we do the entire surgery through the patient's mouth open. We do not make any external cuts on the neck. Second is the laser. This is our precision cutting tool. We use a highly focused beam of light instead of a traditional steel scalpel. Third is microsurgery. We perform this entire procedure looking through a surgical microscope. This gives us the high magnification we need to see tiny tumor margins safely. This is the surgical setup in the operating room. As you can see in the picture, the surgeon sits comfortably. He looks directly through a high-powered surgical microscope. This microscope is attached to a laser micromanipulator. With this setup, the surgeons control the laser beam using a joystick. The laser beam travels straight down a rigid laryngoscope. This scope goes through the mouth and nicely exposes the vocal cords. We use a carbon dioxide laser for this procedure. This CO2 laser cuts the tissue with extreme precision. This precision is very important. It allows our pathologist to properly check the tumor margins under their microscope. Once the tumor is completely removed, we do not put any stitches. We leave the surgical wound completely open to heal naturally on its own over the next few weeks. Here are some actual photos from operating rooms. On the left side, you can see exactly how the patient is positioned. The patient lies completely flat on the table. Notice how the neck is carefully extended. This extension is extremely important. It creates a straight path for the laser beam to reach the vocal cords. We use a strong suspension system to hold the scope securely in place. This is why the surgeon's hands are completely free. Now look at the photo on the right. You can see the surgeon actively working. He is looking directly into the surgical microscope. Notice how comfortably his arms are resting. He uses one hand to control the laser joystick. He uses the other hand to work with tiny micro instruments. This comfortable setup is exactly what gives us perfect stability and precision during this surgery. Here is another look at our complete surgical setup. On the right side of the screen, you can see our surgical instrument table. Notice the different sizes of rigid laryngoscope kept ready. We also have a set of very long and fine micro instruments. We need these special tools to gently hold the tissue and clear the smoke. Now look at the left side of the screen again. Notice the foot pedal placed near the surgeon's foot. The surgeon presses this pedal to actually fire the laser beam. Finally, look at the two pictures at the bottom. This is exactly the view we get through our microscope. You can clearly see the white tumor sitting right on the vocal cord. This perfect, clear view is the absolute key to a successful surgery. Let us now begin with our first part of our presentation. We will study the endolaryngeal microvasculature and anatomy. I can assure you of one very important thing. Treating early glottic cancer with a laser is not just about aiming and firing. We must deeply understand the microscopic tissue planes. Microscopic tissue planes. You must know the hidden blood vessels inside the larynx. And you must know the silent anatomical pathways where a tumor has a tendency to spread. If you do not know these hidden structures, you will fail. You will either leave residual cancer behind or you will permanently destroy the patient's voice. This part of the lecture will act as your spatial guide to the larynx. Let us now learn this anatomy in a completely new way. When we perform open neck surgery, we are taught to learn the anatomy from the outside in. But in laser microscope surgery, we must completely change how we think. We must learn the anatomy of the larynx exactly in reverse. We start our work at the delicate mucosal surface on the inside. Then we meticulously dig our way outward into the deeper tissue. If you do not completely understand these microscopic tissue planes, you will fail. You will either leave residual cancer behind in the deep spaces or you will cause catastrophic, irreversible damage to the patient's voice. This is why your spatial awareness is your most important surgical tool. Let us look at the most fundamental rule of laser surgery. TLM is a strict line of sight weapon. This means you can only cut what you can directly see through your microscope. The oncological rule here is very clear. Achieving cancer control depends entirely on your understanding of the local anatomy. You must map out the microscopic tissue planes in your mind. You must predict the hidden blood vessels before you fire the laser. You must know exactly where the tumor is trying to escape. What happens if you fail to do this? If you do not understand these hidden pathways, you will face a disaster. You will either leave residual tumor behind in the patient, or you will cause catastrophic and permanent damage to their voice. There is absolutely no room for guesswork in this surgery. Let us now look at the layers of the vocal cord. To the naked eye, the vocal cord looks like a simple band of tissue. But for a laser surgeon, it is a highly complex structure. I want you to think of vocal cord like a thick electrical cable. See here. If you carefully peel off the outer plastic layer, the cable still works perfectly. But if you accidentally cut the deep copper wire inside, the signal is completely destroyed. Our surgery works on the exact same principle. We must understand these distinct layers from the outside to the inside. Outside here means from the laryngeal lumen side. First, on the outermost surface, that is the laryngeal lumen surface, we have the squamous epithelium. See this light red color thin layer, this one. Just below it lies the thin basement membrane. See this thin black layer here. Then we have the lamina propria, which has 3 different layers. The superficial layer is called superficial lamina propria, also called as Rinke's space. It is a jelly-like layer. It is a soft and water-rich layer. See this blue, light blue color. Below that, there are intermediate lamina propria and deep lamina propria, which together form a strong ligament called vocal ligament. See this light pink color, 2 layers. The outer is the intermediate lamina propria and the deeper is the deeper lamina propria. Finally, at the very deep, we have thick muscle called vocalis muscle. This muscle is a deep copper wire of our cable. These layers are extremely important for surgeon. They directly decide how deep we will cut with our laser. Let us look at this surgical correlation in more detail in the next slide. This is a detailed diagram of the vocal cord. This slide connects our knowledge about layers of vocal cord to our surgical actions. On the left side, you see 5 anatomical layers. We have seen those 5 layers in our previous slide. Now look at the middle of this slide, where we have defined the function of each layer. First is the squamous epithelium. This layer protects the vocal cord against airflow and mechanical shearing. Second is the basement membrane. This layer prevents the epithelium from detaching during phonation. Third is the superficial lamina propria, also known as Rinke's space. This is a pliable gelatinous matrix and it acts as our primary vibrating mass. Fourth is the strong vocal ligament. It contains an intermediate elastin layer for recoil and a deep collagen layer for tensile strength. Fifth is the thick vocalis muscle. This is a deep structural core that actively regulates the tension, mass and length of the vocal cord. On the right side, you see the European Laryngological Society classifications. We simply call this the ELS classification. If the tumor is very superficial, we do an ELS type 1 cordectomy. We gently peel off this squamous epithelium. We leave the deeper structures completely untouched. This gives the patient a perfectly normal voice. So the three sublayers of lamina propria layer is the vibratory engine of the vocal cord. And the vocalis muscle layer provides power and fine-tuned adjustment. If the tumor infiltrates the vocal ligament, we do an ELS type 2 cordectomy. Here, we remove the mucosa and the entire vocal ligament. We stop exactly at the muscle. We expose the muscle completely, but we do not cut it. Now, what happens if the cancer infiltrates even more deeper? The moment your laser cuts even a single fiber of vocalis muscle, it becomes an ELS type 3 cordectomy. Finally, if the tumor is very deeply invasive, we perform an ELS type 4 cordectomy. This is total excision. We remove the entire vocal cord right down to the inner cartilage. You must understand these exact layers before every single TLM surgery. Let us now look at a very practical surgical technique called hydrodissection. We know that the CO2 laser is highly absorbed by water. Rinke's space is naturally a soft and water-rich layer. During surgery, we inject a simple solution of saline directly into this space. See here. This injection acts as a brilliant diagnostic test right on the operating table. Look at the blue fluid in the diagram on the screen. If the tumor lifts up smoothly like a small water blister, it is good news. It means the cancer is confined superficially. But what if the tumor remains fixed and does not lift up? This tethering is a danger sign. It tells us that the cancer has invaded deep into the vocal ligament. Why is this lifting so important for the patient? If the tumor lifts, we can safely peel it off using the laser. We can completely save the deep vocal ligament and the vocalis muscle. This is exactly what we do in an ELS type 1 or type 2 cordectomy. Saving these deep structure gives the patient an excellent near normal voice. Let us move to a very interesting anatomical fact. We just discussed how we peel off the tumor layer. But why is it safe to take a surgical margin of just 1 to 2 millimeters? Why does this cancer not spread microscopically very fast? The answer lies in our embryology. Look at the diagram on the screen. The supraglottis above has a very rich lymphatic network. The subglottis below also has a very good lymphatic network. But the true vocal cord itself has incredibly fewer or sparse lymphatics. We simply call this the lymphatic void. Because there are almost no lymph channels here, the tumor stays localized for a very long time. This lack of lymphatic drainage makes early glottic cancer very forgiving for this surgeon. This is the exact reason why we can safely take very narrow surgical margins. We can achieve a complete oncological cure while saving maximum healthy tissue. Let us now talk about the blood supply of the glottis. Why is bleeding such a big problem in laser surgery? The CO2 laser is an excellent cutting tool, but it has one major limitation. It can only stop bleeding from tiny blood vessels that are smaller than 0.5 millimeters. Any vessels larger than this will bleed during surgery. Why is blood our worst enemy in the operating room while doing TLM? Blood is mostly made up of water, and the CO2 laser is completely absorbed by water. A single drop of blood will act like a strong shield. It will instantly stop the laser from cutting the tissue. It will completely ruin your clear view through the microscope. Now you might think of using unipolar electrical cautery to stop this bleeding. But that is a very bad idea. The heat from the cautery will severely burn the tissue edges. This burning completely destroys your delicate surgical margins. Your pathologist will never be able to tell if the cancer is completely removed. That is why you must avoid bleeding at all cost. Let us now learn about the exact blood supply. While doing TLM, we have to predict where these blood vessels are hiding before we cut. Look at the anatomical diagram on the screen. The larynx gets its primary blood supply from the superior laryngeal artery. You can see it entering from the top left of the diagram. This main artery comes down and divides into a complex network of smaller vessels. Before we look at these specific branches, remember our golden rule. The CO2 laser can only seal vessels that are smaller than 0.5 millimeters. If you blindly cut into any of these larger arterial branches, they will bleed. And we already know the exact oncological risk of this bleeding. Blood will instantly absorb your laser beam and make you blind. If you then panic and use heavy electrical cautery to stop the bleeding, you will burn the tissue edges. This burning completely ruins your surgical margins. Your pathologist will never be able to tell you if the cancer is completely removed. Therefore, you must memorize this arterial map to avoid these larger vessels. In my previous slides, I explained you why bleeding is so dangerous for the CO2 laser. Because blood absorbs the laser and ruins the surgical view. This current slide provides the actual visual roadmap of where those exact bleeding dangers are hiding. Let us look at the actual dissected specimen on the screen to understand arterial supply. It shows the exact vascular anatomy we must safely navigate. At the top, you see the main superior laryngeal artery. Its first branch is the epiglottic artery, marked as EA. This branch goes up and is found in almost every single patient. The main trunk when moves forward and divides into two key arteries. These are the posterior inferior artery or PIA and the anterior inferior artery or AIA. Look closely at the PIA. It completely splits into two distinct parts. These are the anterior posterior inferior artery and the posterior inferior artery. The posterior inferior artery is highly dangerous. It is the main artery that will bleed heavily when you dissect in the region medial to the vocal process. Next, look down at the bottom right for the paracommissural artery marked as PCA. This artery comes from behind to provide vascularity to the area just inferior to the anterior commissure. This is your main source of anterior bleeding. Both the PCA and AIA are the main arteries that will bleed when you operate near the anterior commissure. Finally, notice how all these vessels connect to form a multiple transverse arterial network. You must memorize these exact bleeding points before you fire the laser. Look at this summary table now. This table directly breaks down our primary hemorrhage sources during surgery. First is the epiglottic artery. Since it ascends to the supraglottis, we rarely encounter it in early glottic cases. Next is the posterior inferior artery. Notice the red blood drop icon next to it. This is your primary source of posterior hemorrhage. If you cut this near the arytenoid vocal process, it will rapidly flood the airway. Third is the anterior inferior artery. You will encounter this vessel during deep lateral resections near the thyroid ala. Finally, look at the paracommissural artery at the bottom. It also has a red blood drop icon. This is your primary source of anterior hemorrhage. It will bleed profusely during anterior commissurectomy or when chasing a subglottic tumor. You must keep this exact table in your mind before you fire the laser. Let us now talk about the importance of a very critical anatomical part of glottic, anterior commissure. This is a highly dangerous anatomical trap region. Look at the V shape in the diagram where the two vocal folds meet at the front. This exact junction is the anterior commissure. It is directly attached to the hard thyroid cartilage in the front. It is anchored there by a very specialized structure called Broyles ligament. Now I want my radiation oncology colleagues in the audience to pay close attention. This specific anatomical junction explains exactly why surgeons frequently send bulky anterior tumors directly to you for radiotherapy. It explains why we often keep the laser away from this area. In the next slide, I will explain exactly what makes this ligament so dangerous for the laser surgeons. Let us look closely at exactly what makes the anterior commissure so dangerous. Look at this conceptual diagram on the screen. Everywhere else in the larynx, the cartilage is perfectly protected by a tough shield called the inner perichondrium. See this. But look exactly at the center where Broyles ligament attaches here. At this exact spot, the inner perichondrium is completely absent. This creates a major anatomical breach. A tumor hiding here has a direct and open highway right into the raw thyroid cartilage. It easily spreads through the Sharpie's fiber and tiny blood vessels. There is another problem here. Imagine firing your CO2 laser directly onto this bare cartilage. It will cause severe damage to the laryngeal framework that looks just like radionecrosis. Furthermore, it is nearly impossible for you to check for microscopic cancer cells deep inside the cartilage. This naturally leads to unacceptably high rates of positive surgical deep margins. This is exactly why we consider definitive radiotherapy to be clinically superior for these specific tumors. Radiation successfully delivers a uniform and sterilizing dose to the entire micro-invasive area. Most importantly, it destroys the cancer without destroying the structural and mechanical integrity of the patient's larynx. Let us now move away from the dangerous visible mucosal surface. Look at the deep, fat-filled anatomical compartments inside the larynx. These are the hidden escape routes where tumors aggressively spread and upgrade their staging. Look at the diagram on the left side of the screen. This is paraglottic space or PGS. It is the lateral void sitting directly between the vocal cord and the hard thyroid cartilage. Now look at the diagram on the right side. This is the pre-epiglottic space or PES. It is a large fat-filled compartment positioned just above the anterior commissure. If an aggressive tumor climbs upward from the anterior commissure, it will directly invade this space. In the next two slides, we will discuss exactly why these two specific spaces control our entire choice between surgery and radiation. First, look at the paraglottic space or PGS. This is the lateral fat pad sitting directly between the vocal cord and the thyroid cartilage. How do you know if a tumor has entered this space? When you examine a patient with a T2 tumor, look closely at the vocal cord mobility. If the vocal cord is stiff or has impaired mobility, it is a major warning sign. It means the cancer is no longer just a surface mucosal issue. It has aggressively infiltrated deep into the vocalis muscle and entered this lateral space. Now look at the surgical limit on the right side of your screen. Standard ELS type 1 to 4 cordectomies only clear the medial border of this space. They cannot safely clear the deep lateral fat. To remove cancer from deep inside the paraglottic space, you must perform massively extended type 5 resections or even an open partial laryngectomy. These massive excavations completely destroy the patient's phonatory apparatus. The patient will be left with a permanent, harsh and breathy whisper. This is exactly why primary radiation therapy is functionally superior for those deeply infiltrative T2 scenarios. Let us now move to second hidden escape route. This is the pre-epiglottic space or PES. Look at the diagram showing the tumor climbing upward from the anterior commissure. This space is incredibly rich in lymphatics. The moment a tumor breaches this space, the patient's risk of nodal metastasis immediately skyrockets. But there is another major clinical challenge here. This fat-filled space has a very poor blood supply. This causes severe tissue hypoxia. And we all know that hypoxic tumors are resistant to standard radiotherapy doses. So how do we treat a tumor hiding in the pre-epiglottic space? A standard transoral laser approach is completely insufficient. To achieve a safe oncological cure, these patients may require escalated dose IMRT. They might also need advanced chemoradiation protocols or an open partial surgery. You must always evaluate these deep escape routes before you take a patient to the operating room. Let us bring all of this anatomical knowledge together here. Look at this summary table. It shows exactly how we tailor our treatment to the specific anatomy. First, look at the superficial glottic tumor. If the cancer is strictly in the epithelium or Rinke's space, the laser is our primary choice. Why? Because it allows perfect micro peeling while safely preserving the deep vocalis muscle. Second, look at the anterior commissure. If the tumor heavily infiltrates this area, radiotherapy is frequently the superior choice. This perfectly avoids burning the bare thyroid cartilage and prevent radionecrosis. Third, look at deep paraglottic invasion, which presents as an impaired vocal cord. Again, we strongly prefer radiotherapy here. It successfully treats the deep disease without requiring a massive voice-destroying surgical excavation. Finally, look at the bottom row for the pre-epiglottic space. A tumor hiding here faces hypoxic tissue resistance and a massive spike in lymphatic risk. A simple transoral laser is absolutely insufficient here. These complex patients require escalated IMRT, advanced chemoradiation, or open surgery. You must always match the right tool to the exact anatomical threat. To conclude our first segment of lecture, I want you to remember one golden rule. Early glottic oncology is an absolute exercise in spatial awareness. Look at the three pillars on your screen. First, you must see the anatomy in true 3 dimensions. You must train your brain to visualize the larynx in reverse. You must respect the microarchitecture from the superficial mucosa down to the deep vocalis muscle. Second, you must actively predict the bleeding map. You must anticipate and avoid vessels that are larger than 0.5 millimeters. This keeps your laser from being neutralized by a pool of water-rich blood. Finally, you must deeply fear the anatomical traps. You must know exactly when a tumor breaches the anterior commissure or deep fat-filled spaces. These hidden escape routes dictate a critical clinical shift. They tell us exactly when to move away from surgical laser and defer to the linear accelerator. By mastering this exact spatial awareness, we can perfectly tailor our treatment for every single patient. So with this, we finished our first topic on anatomy and microvasculature of the glottic region. Let us now move on to our next topic, pre-operative patient selection and triage for laser surgery. This is the most critical phase of our entire treatment plan. Listen to me very carefully now. Success is determined in the clinic itself, not the operating room. Why is this statement absolutely true? In traditional open surgery, we can actively create our own access. If we cannot see a tumor, we simply extend our incision or cut more tissues. But in laser surgery, we do not have that luxury. I told you earlier, TLM is a strict line of sight weapon. If you select the wrong patient in outpatient clinic, you will face a disaster in the operating room. You will either leave residual cancer behind or completely destroy the patient's voice. In next few slides, we will break down the exact clinical framework you must use to safely select your patients for TLM. Let us compare a traditional open surgery with laser surgery. Look at the left side of the screen. In open head and neck surgery, we can actively create our own success. If we cannot see a tumor, we simply extend our incision. If we cannot divide more muscle or remove overlying cartilage to get a better view. But look at the right side of the screen. In transoral laser microsurgery, we are strictly denied that luxury. TLM is an absolute line of sight discipline. This brings us to the golden rule of laser surgery. If you cannot perfectly visualize the entire tumor boundary through a rigid laryngoscope, you cannot safely resect it. It is really that simple. If you cannot see the margins clearly, you must not attempt TLM. These are three pillars for a successful selection of patients for TLM. First is the anatomical imperative. This simply asks one question. Can we physically reach the larynx? For that, we need to evaluate the patient's laryngeal exposure. If we cannot clearly see the entire surgical area, we cannot safely use the laser. Second is the oncological assessment. This asks our second question. Can we safely remove the complete tumor? We must carefully map out the exact boundaries of the cancer. We must make sure the tumor is not hiding in deep, dangerous spaces. Finally, we have the physiological and psychological triage. This asks our final, very human question. Can the patient tolerate the final outcome? We must look at their lung capacity, their daily lifestyles, and their voice needs. We treat human beings, not isolated larynges. If a patient fails any of these three pillars, they are not a safe candidate for laser surgery. First pillar, the anatomical imperative. Can we physically visualize the entire surgical field? Look at the glass bottle example on the left side of your screen. Imagine trying to paint the inside base of this narrow, curved bottle. You are only allowed to use a long, rigid brush inserted through the neck. If the neck is too narrow or the curve is too sharp, you simply cannot reach your target. This is the exact mechanical challenge for laser surgery. Before we even evaluate the cancer, we must strictly evaluate this surgical corridor. A good laryngeal exposure allows us to use a large bore laryngoscope. We use scopes like the Dido or Lindholm to get a wide panoramic view of the vocal cords. But a difficult exposure forces us to use a very small bore scope like the Hollinger. This badly compromises your microscopic depth perception and the cutting angle of your laser beam. If you cannot safely reach the target, you cannot safely cure the patients. To objectively measure our anatomical exposure, we use the laryngoscope. This scoring system was created by Professor Cesare Piazza. It uses 11 simple clinical parameters evaluated during a standard physical exam before you even decide for TLM for early glottic cancer. Let us look at the first 6 parameters on this table. This column shows the clinical parameters. This column shows whether a particular clinical parameter gives optimal anatomy and exposure. This column shows whether a particular clinical parameter gives challenging anatomy and exposure. First is neck flexion and extension. If the patient has stiff neck joints, like in cervical spondylosis, we cannot properly position their head. Second is the thyromental distance. For a safe exposure, it must be greater than 6.5 cm. Third is the inter-incisor gap. This is simply how wide the patient can open their mouth. We need a mouth opening of at least more than 4 centimeters. Fourth, we must check for trismus. If the jaw muscles are tight and the mouth cannot open, our rigid scope will simply not pass. Fifth is the upper jaw dental status. Prominent upper teeth acts as a severe physical block. They push the scope down and completely ruin our direct line of sight. Sixth, mandibular prognathism. This simply means a protruding lower jaw. This also severely changes our entry angles and blocks our view. Seventh parameter is micrognathia. This simply means the patient has an undersized lower jaw. If it is absent, it is good. If it is present, then it will give a challenging exposure. Eighth parameter is macroglossia. A large, thick tongue will push against our scope and completely block the visual field. Ninth parameter is previous neck treatment. If the patient has a history of open cervical surgery or prior radiotherapy, their neck tissues will be very stiff. This severe fibrosis prevents us from lifting the larynx properly. 10th parameter is the modified Malampati score. A score of class 3 or class 4 indicates severe crowding in the throat. Class 1 or 2 gives adequate exposure. Finally, 11th parameter is body mass index or BMI. A BMI of 25 or more indicates an overweight patient. Thick, heavy tissue around the neck and chest makes placing a rigid laryngoscope physically difficult. By evaluating all these 11 parameters, we can generate a total score. Now that we have calculated the total score, what does it actually mean? How do we decide if a patient has a good exposure in order to have a good TLM? If your patient has a cumulative score of less than 6, you have a green light. This guarantees an excellent laryngeal exposure 94% of the time. But what if the score falls into middle range, exactly between 6 and 9? In this exact range, you only have a 60% chance of a good surgical view. This means there are a significant 40% risk that your view will be compromised. And if the score is greater than 9, you are entering the dangerous red zone. There is over a 70% probability that your exposure will be difficult or impossible. So this is how you assess whether a particular patient is suitable candidate for TLM or not. You must check it for every patient if you are planning to do TLM. For a very fast assessment in a busy OPD, you can simply use the mini laryngoscope. This rapid tool relies on just 4 things. These are the inter-incisor gap, thyromental distance, cervical mobility, and the Malampati score. This brings us to an absolute clinical rule. If exposure is impossible, curative laser surgery is strictly contraindicated. You must immediately triage these patients to radiotherapy. Let us move to the second pillar of our triage process for TLM. This is the oncological assessment. Once we know we can safely reach the larynx, we must map the exact boundaries of the tumor. We must prove the cancer is biologically suitable for the laser. Before we make any surgical decision, we have a strict prerequisite. We should use narrow band imaging or NBI. We use this to perfectly outline the superficial spread of the disease. We sometimes also rely on a CT or MRI to prove there is absolutely zero deep invasion. Now look at the green light on your screen. These are our ideal candidates for laser surgery. First are the T1A mid-cord lesions. Look at the diagram showing the green tumor sitting exactly in the middle third of one vocal cord. This is the absolute best scenario for a laser surgeon. It guarantees a rapid single-day cure with perfectly preserved voice quality. Second are the superficial T1B lesions. In this case, the cancer touches both vocal cords, but there is a very strict condition to keep them in this green zone. The tumor must completely spare the deep ligaments and the anterior commissure. If your patient fits these exact profiles, you can confidently proceed with laser surgery. Let us now see borderline candidates where you must proceed with high caution. First, look at the anterior commissure. As we discussed in the anatomy section, this exact area lacks a protective inner perichondrium. Tumors hiding here have a direct microscopic pathway straight into the raw thyroid cartilage. Resecting this disease safely requires a highly experienced surgeon and an extended cordectomy. Next, let us evaluate T2 lesions. I want to make an important clinical point here. I know that the current AJCC 8th edition combines all these into a single T2 category. But for surgical triage, we must still conceptually separate them based on vocal cord mobility. Look at the slide for what we functionally call T2A lesion. This means the tumor extends superficially to the supraglottis or subglottis, but the vocal cord still moves completely normally. These patients can still be carefully considered for laser surgery. But the functional T2B lesions are a completely different clinical story. In these patients, the vocal cord has impaired mobility. This impaired movement is a major warning sign. It explicitly signals deep invasion into the vocalis muscle. If you use a laser here, your local disease control drops significantly to just 57%. Furthermore, the patient's voice outcome will be permanently poor. This is exactly why we strongly favor primary radiotherapy when there is impaired mobility. Let us now look at the absolute red light in our oncological assessment. These are candidates where TLM is absolutely contraindicated. As a safe surgeon, you must draw a hard line in the sand. If a patient presents with any of these 4 features, TLM is strictly contraindicated. First is vocal cord fixation, which functionally means it is a T3 tumor. A fixed cord indicates massive invasion deep into the paraglottic space or the cricoarytenoid joint. Fixation of the arytenoid cartilage is an absolute veto for this surgery. Second is any macroscopic cartilage erosion. If the tumor has already infiltrated into the hard thyroid or cricoid cartilage, you cannot use a laser. Attempting to scrape cancer cells off bare cartilage will only guarantee an oncological failure. Third is massive invasion into the deep spaces. If the tumor completely fills the pre-epiglottic or paraglottic fat pads, it cannot be safely cleared from the inside out. Finally, we have extensive subglottic extension. Tumors that spread far downward toward the cricoid ring are practically impossible to perfectly visualize and resect from above. If you see any of these red flags in the clinic, you must immediately abandon the transoral plan. You must triage these patients to definitive chemoradiation. Let us now enter the final phase of our pre-operative triage. We must treat the human being, not just the isolated larynx. A standard type 1 or type 2 cordectomy is generally very safe. The voice is good after these procedures. It rarely causes any long-term swallowing issue for the patient. But what happens if you face a bulky tumor? If you have to remove the arytenoid cartilage or a massive portion of the glottis, the vocal cords will no longer close properly. This creates acute post-operative glottic incompetence. And this means the patient will immediately aspirate. Because of this severe functional risk, we must rigorously evaluate 3 specific human factors before we ever proceed to the operating room. First, look at the lung icon on the left. We must strictly assess their pulmonary reserve and the risk of fatal aspiration. Second, look at the middle icon. We must consider sparing their anatomical radiation bank for the future. And third, look at the briefcase icon on the right. We must carefully evaluate their occupational compliance and daily vocal demands. In the next 2 slides, we will focus closely at exactly how to evaluate these crucial human factors. Look closely at the first two human factors on this slide. First, look at the balance scale on the left. We must carefully weigh the depth of our surgical resection against the patient's native lung capacity. We must ask a very specific triage question. Does this patient have the FEV1, the FVC, and the mechanical cough reflex to safely clear microaspirations? Imagine a frail elderly patient with severe COPD. If you perform an extended laser resection, they will experience glottic incompetence and they will aspirate. Because of their poor lungs, they will likely develop a fatal aspiration pneumonia. For these frail patients, definitive radiotherapy is always the safer choice. Now look at the glowing green battery icon on the right side of your screen. This presents the patient's radiation bank. What does radiation bank mean? Many of our laryngeal cancer patients are heavy smokers. Because of this, they carry a very high lifetime risk of developing a second primary tumor in the head and neck. If we treat their first early glottic cancer with laser surgery, we leave their radiation bank completely intact. This is like keeping radiation as a future treatment modality in your bank safely. If they develop a new tumor or a local recurrence 10 years later, radiotherapy remains a highly viable curative weapon. Preserving this radiation bank is one of the absolute greatest long-term advantage of upfront laser surgery. Let us look at the final two human factors in our triage process. Look at the calendar icon on the left side of your screen. This represents patient compliance and logistics. After laser surgery, the patient requires strict, highly vigilant endoscopic follow-up to catch any early recurrence. If a patient lives very far away or is historically non-compliant, choosing laser surgery is dangerous. However, imagine a daily wage worker who simply cannot afford to miss work for 6 weeks of daily radiotherapy. For this specific patient, one-day outpatient laser procedure is an absolutely excellent choice. Now look at the microphone icon on the right side of the screen. This represents the patient's occupational vocal demands. If a patient requires a deep transmuscular type 3 or a total type 4 resection, the glottis will not close perfectly. It will inevitably leave the patient with a permanently breathy and weak voice. For a retired patient, this functional outcome might be perfectly acceptable. But for professional voice users like singers, teachers, or lawyers, this outcome could be completely career ending. In these high-risk scenarios, an upfront multidisciplinary discussion is absolutely mandatory. You must involve your speech-language pathologist from day one before making any final surgical decision. Let us now summarize everything we have discussed. Look at this flowchart. When a patient presents with early glottic cancer, they must successfully pass through 3 distinct gateways. Think of these gateways as strict clinical checkpoint. Gate 1 is the anatomical assessment. We use the laryngoscope to evaluate their surgical exposure. If the score is greater than 9, they will fail the first gateway. You must immediately triage them to radiation. If they pass, they move to gateway 2, which is the oncological assessment. We actively look for ideal superficial tumors like the T1A or superficial T1B lesion. If we see absolute contraindications like vocal cord fixation or cartilage erosion, they fail the second gateway. If the tumor is oncologically appropriate, they finally reach gateway 3. This is the physiological and psychosocial assessment. We must confirm they have adequate pulmonary reserve and a viable logistical profile. If they are frail and at high risk for aspiration, we must choose definitive radiotherapy. But look at the bottom of the screen. If a patient successfully passes all 3 gateways, you have the absolute green light. You can safely and confidently proceed with transoral laser microsurgery. Let us quickly summarize the most important points from this segment of our lecture on patient selection and triage for TLM. Look at the summary checklist on your screen. There are 4 key takeaways for TLM triage. First, you must remember that laser surgery is absolutely unyielding. Your surgical success is strictly controlled by your pre-operative visualization. If you cannot perfectly see the tumor, you absolutely cannot resect it. Second, you must routinely use the laryngoscope in your outpatient clinic. You must objectively calculate your surgical exposure risk. Remember that a score over 9 strictly prohibits curative laser surgery. Third, you must actively respect the oncological red lights. Vocal cord fixation and cartilage erosion are absolute contraindications. You must never try to force a surgical cure when these red flags are present. Finally, always remember to treat the human being, not just the cancer. We must carefully weigh the exact depth of your required resection against 2 critical human factors. These are the patient's pulmonary reserve and their daily occupational voice demands. This concludes our second topic on patient selection and clinical triage. You now have a strict clinical framework to safely select your surgical candidates. In our next segment, we will shift our focus entirely to the laser machine itself. We will thoroughly discuss laser biophysics, dosimetry, and the exact hardware you will use in the operating room. Let me introduce the surgical weapon itself. To the general public, a laser is often seen as a magic light that simply makes things disappear. But in operating room, there is no magic at all. Laser surgery is completely based on strict physics and heat control. When you hold a normal steel knife, you can actually feel the tissue as you cut. But a laser gives you absolutely zero physical feeling. Your surgical precision, your safe cancer margins, and your patient's life depends entirely on your scientific knowledge. You must completely understand how the laser works and exactly how much energy to use. If you do not understand how this light reacts with human tissue, the results will be disastrous. A lack of knowledge will lead to deep burns in healthy tissue, ruined cancer margins, and deadly airway fires. So let us break down the exact physics, the machine parts, and the strict safety rules. You must deeply understand these basic rules before you even press the laser pedal. Let us start by understanding the basic word laser. Laser stands for light amplification by stimulated emission of radiation. Look at the simple diagram on your screen to see exactly how this is created. Inside the machine, we have a central glass tube filled with a specific gas mixture. This gas mixture is called our lasing medium. In our operating rooms, this gas is usually a mixture of carbon dioxide, nitrogen, and helium. At the bottom of the diagram, you can see a high voltage power supply. When we turn the machine on, this electrical energy enters the tube and excites the gas atoms inside. These excited atoms want to return to their normal, quiet resting state, but they drop back down their normal state. They release their extra energy as tiny particles of light. Now look closely at two ends of the glass tube. On one end has a perfectly solid mirror and the other end has a partially open mirror. The new light particles bounce rapidly back and forth between these two parallel mirrors. As they bounce, they crash into other atoms and force them to release even more light particles. This creates a massive chain reaction inside the tube. Finally, a perfectly straight and incredibly powerful beam of light shoots out through the partially open mirror. This single highly intense beam of light is your surgical scalpel. Let us now compare a traditional surgery with laser surgery. Look at the standard steel knife on the left side of your screen. When you use a normal cold steel scalpel, you get immediate physical feedback in your fingers. You can actually feel the physical resistance of the tissue as you push and cut. Now look at the laser instrument on the right side of the screen. With a laser beam, you get absolutely zero physical feeling. You are cutting tissues using pure light and applied quantum physics. Because your hands cannot feel the tissue, your surgical precision depends entirely on your scientific knowledge. Your patient's safety and your exact cancer margins are controlled entirely by your mastery of heat and thermodynamics. If you do not understand exactly how this light reacts with the tissue, the result will be very bad. Ignorance will lead to deep thermal burns and completely ruined cancer margins. This is exactly why a laser surgeon must first become familiar with biophysics of laser. There are various different types of medical lasers. You can see multiple options like Ruby, Andy-YAG, ER-YAG, diode, argon lasers, etc. But look closely at the highlighted box at the bottom. For early laryngeal surgery, the carbon dioxide laser is our absolute gold standard. Why is this specific laser the standard? It operates at a very specific wavelength of 10,600 nanometers. At this exact wavelength, the ultimate target for the laser surgery is simply water. Human laryngeal mucosa and the vocalis muscle are naturally made up of up to 90% water. When the laser beam hits the tissue, this intracellular water instantly boils and turns into steam. This rapid vaporization gives up three massive clinical advantages. First is ultimate precision. The tissue destruction is purely superficial. Collateral thermal damage is strictly limited to less than 0.01 millimeter. Second is simultaneous hemostasis. While it cuts, the laser beam automatically seals small blood vessels up to 0.5 millimeter in diameter. This automatically guarantees a perfectly dry and clear surgical field. Third is absolute safety. Because the water instantly turns to steam, 99% of the intense heat is immediately released into the air as vapor. The heat does not stay behind to burn the deep, healthy vocal tissues. Let us look specifically at the unique physical advantages of the carbon dioxide laser. As you can see at the top of the slide, this laser operates in the far infrared spectrum at exactly 10,600 nanometers. Because this specific wavelength is completely invisible to human eye, it strictly requires a coaxial helium neon red emitting beam. This red beam shows you exactly where your invisible surgical cut will occur. The absolute target chromophore for this specific energy is simply water. Human laryngeal mucosa and the deep vocalis muscle are naturally composed of 70 to 90% water. To truly understand how this cuts human tissue, look at the wet sponge analogy on your screen. On the left side, we have a green KTP laser. Because the KTP laser targets hemoglobin, it passes completely through the clear water on the surface of the sponge. It only burns the red vascular structure deep inside the tissue. Now look at the red CO2 laser on the right side of your screen. When the carbon dioxide beam hits the wet surface of the sponge, the water instantly boils and vaporizes into a plum of steam. The intense energy does not penetrate deep into the sponge. This rapid intracellular vaporization creates an exceptionally precise cut. It strictly restricts any collateral thermal damage to just a fraction of a millimeter. Let us see exactly how we control the true cutting power of the laser beam. Look at the fundamental mathematical formula on your screen. Simply setting your machine to 4 watts tells you absolutely nothing about its actual surgical power. The only functional measurement we must care about is the power density. This is defined as the exact concentration of laser power over a specific surface area of human tissue. Look closely at the denominator of the equation. You will notice that the radius of the laser beam is mathematically squared. Because this radius is squared, the spot size becomes the single most critical variable in laser surgery. Observe how the red beam visually narrows from left to right on the diagram. If you reduce your spot size by exactly half, you do not merely double the energy. You automatically quadruple your effective cutting power. This high concentration of energy is precisely how we achieve precision of laser beam into vocal cords. Let us look at exactly how we practically use spot size in the operating room. Look at the diagram on the left side of your screen. This represents our standard cutting mode. Here we use a tightly focused spot size of roughly 250 micron. This is extremely small, measuring just 0.25 millimeters. We strictly use this as a standard working distance of 400 millimeters. And at this perfect focus, the laser creates a micro layering destruction effect. It vaporizes the tissue deeply, but it only removes a very few microns with every single pass. This is exactly what gives us such extreme surgical precision for our oncological margins. But what happens when you inevitably encounter bleedings from small vessels? Look at the right side of your screen. This represents our coagulating mode. To stop the bleeding, you simply pull the laser beam out of the focus. By intentionally increasing the spot size, your overall power density drops instantly. This simple physical action completely transforms your surgical weapon. Your sharp cutting tool instantly becomes a highly effective tissue sealant. It will safely and successfully coagulate microvessels up to 0.5 millimeters in diameter. This automatically guarantees a perfect dry and clear surgical field without needing to change your instruments. Let us now discuss a very crucial concept in laser biophysics. Look at the graph on your screen showing thermal relaxation time, or TRT. TRT is the exact amount of time a tissue needs to naturally cool down. Specifically, it is the time required for tissue to cool down to 50% of its peak temperature after absorbing laser energy. Look at the red temperature curve on the graph. When the laser beam hits the tissue, the heat spikes instantly. But it takes a much longer time for the tissue to safely cool back down. Notice the dotted lines showing the irreversible thermal necrosis threshold. If you apply laser heat faster than the tissue can cool down, you cross this dangerous line. The intense heat will rapidly conduct laterally into the healthy side tissues. This sideways heat conduction causes severe black charring of the tissue. It will completely obliterate your exact pathological margins. Even worse, it will cause permanent thermal damage to the deep vocal ligament. To strictly avoid this surgical disaster, your energy delivery must also be pulsed. Using carefully timed short pulses respects the TRT and gives the delicate tissue enough time to safely cool down. Let us look at exactly how we deliver this laser energy to human tissues. Look at the table on your screen showing the three distinct delivery modes. First, look at the top row showing the continuous wave mode. As you can see from the red block, the energy output is completely uninterrupted. This mode is extremely high risk in early glottic cancer. It rapidly applies heat faster than the tissue can naturally cool down. This causes massive lateral heat conduction and severe black charring. You must never use this continuous mode when you need precise oncological margins. Next, look at the middle row showing the super pulse mode. This represents our standard working mode in the operating room. It delivers high energy in short, perfectly timed bursts. It instantly surpasses the vaporization threshold and then cleanly shuts off. This critical resting phase gives the delicate tissue enough time to safely cool down. Finally, look at the ultra pulse mode at your bottom of your slide. This is the absolute optimal setting for transoral laser microsurgery. It delivers exceptionally high peak power in mere microseconds. The tissue completely vaporizes before any heat has the chance to conduct sideways. This produces a pristine, cold steel-like cut with virtually zero thermal charring. When you are dissecting deep near the delicate vocal ligament, using ultra pulse is strictly mandatory. Let us look at the visual activation curves on your screen. This slide shows exactly what the machine is doing when you press the foot pedal. We call this the duty cycle. It is the total amount of time that the laser energy is actually interacting with the human tissue. Look at the top blue and red line. This represents the continuous wave. The laser energy is constantly on, which gives a high average energy. This is very useful if you want a primarily coagulative effect to stop bleeding. But the heavy trade-off is a massive increase in thermal damage. Now look at the middle curve. This is the super pulse. Notice the dark spaces between the sharp red energy spikes. These empty spaces represents the time off between these short pulses. This short resting time is exactly what allows the tissue to safely cool down. Finally, look at the bottom curve. This represents the ultra pulse. The energy spikes here are extremely tall and very narrow. The machine delivers massive peak power in just a few microseconds. It strictly surpasses the ablation threshold to instantly vaporize the cancer cells. It does this perfectly before any heat can leak sideways into the healthy vocal cord. And on the right side of your screen, you see our golden rule again. Your true cutting power is a strict balance between your machine wattage and your spot size. Always remember this simple rule in the operating room. If you intentionally pull the beam out of the focus, your spot size increases. This instantly drops your power density and changes your sharp cutting tool into a safe coagulator. Let us look at the specialized hardware we need in the operating room. We call this the anatomical hardware chain. Look at the top of the diagram on your screen. This is the micro manipulator and the scanner. This device attaches directly to your surgical microscope. It uses a special computer technology called AccuBlade. This system uses tiny mirrors to quickly move the laser beam back and forth. This is extremely important because it completely removes any natural shaking from your hands. It helps you create a perfectly smooth and even cut every single time. Second, look at the middle of the diagram. This is our true vertical suspension system. We strictly use the Boston medical system that attaches firmly to the operating table. This setup safely opens the larynx to give us the maximum possible view. Because it does not use standard chest levers, it does not crush the patient's chest while they sleep. Finally, look at the bottom of the diagram. This is our specialized surgical laryngoscope. It must always have a dull matte finish. If your laser beam accidentally hits the scope, the dull metal absorbs and scatters the light safely. It strictly prevents the hot beam from bouncing into the healthy throat tissue. You must also connect a high volume smoke evacuator directly to this scope. When the laser vaporizes the cancer, it creates a thick cloud of smoke. This smoke immediately blocks your vision, and it can actually carry dangerous viral DNA like HPV. You must constantly suction the smoke away while working at a strict distance of 400 millimeters. Let us now look at the computer screen of the laser machine. This is exactly what you will see in the operating room. Look at the top center of the screen. You see the word SurgiTouch. This is the main operating software of the laser machine. It basically translates what you want to do into an actual laser output. Now look at the bottom left corner. This is where you set your power in watts and your pulse modes. As we discussed earlier, this is where you choose your super pulse or continuous wave settings. Next, look at the top left corner. This is the scanner function. The scanner is a very important computer software. It uses tiny internal mirrors to move the laser beam automatically. Finally, look at the right side of the screen. You see the acute blade and shape settings. Here, you can tell the computer exactly what shape you want to cut. You can easily choose a straight line or a curved line. You also select the exact size of the cut, like the 2 mm. When you select a shape and depth, the software does the math for you. It automatically calculates the exact power and resting time needed for that specific cut. This technology is extremely helpful for us. It completely removes human error and any natural hand tremors. It guarantees a perfectly smooth and uniform cut every single time. Let us now see the most feared complication in the operating room. An airway fire is the single most catastrophic and deadly complication in transoral laser microsurgery. Look at the large red triangle in the center of the slide. This represents the classic fire triad. For fire to happen, you strictly need 3 specific things to come together at this exact same time. First, look at the top of the triangle. You need a massive heat source, which is your active CO2 laser. Second, look at the bottom right corner. You need a physical fuel source to burn. In our operating room, this fuel is usually the plastic endotracheal tube or the patient's biological tissue. Finally, look at the bottom left corner. You need a strong oxidizer to feed the flames. This oxidizer is the combination of oxygen and nitrous oxide gases provided by your anesthesia team. If your hot laser beam accidentally hits a standard plastic tube in a highly oxygenated airway, it will act exactly like a blowtorch. See, like this. The result for your sleeping patient will be completely devastating. Therefore, we must strictly follow rigorous safety protocols before the surgery begins. We must systematically break this deadly triangle before you ever press your foot on the laser pedal. Let us look at exactly how we safely break this deadly fire triangle in the operating room. Look at the 3 pillars of safety on your screen. First, we must neutralize the fuel source. Look at the endotracheal tube icon on the left. You must always use a specially designed laser resistant tube that has 2 separate cuffs. It also strictly follows the methylene blue protocol. You must inflate the top cuff of the tube with sterile water mixed with a dark blue dye. If your laser accidentally hits and bursts this cuff, the blue water will instantly flood the surgical field. This immediately puts out any small fires and gives you a clear visual warning to stop the laser. Second, we must neutralize the oxidizer gas. Look at the gas meter icon in the center of your screen. You must clearly communicate with your anesthesia doctor before you ever turn the laser on. They must drop the oxygen level to the absolute minimum, ideally below 95% or just room air. You must also strictly ban the use of nitrous oxide. Nitrous oxide pools inside body cavities and acts as a massive accelerant for explosions. Finally, we must physically protect against the extreme heat. Look at the wet sponge icon on the right side. You must actively pack the exposed tube and the subglottic area with wet neurosurgical cotton sponges. These are commonly called neuropatties. These sponges act as a physical heat shield for the tissues. But you must remember one absolute rule for the entire surgery. These sponges must be kept continuously dripping wet at all times. If the hot laser beam dries them out, they will instantly change from a safe heat shield into a deadly fire source. Despite our best efforts and strict safety protocols, an airway fire can still happen. If this terrifying event occurs, you must instantly follow the strict fire management directive on your screen. There is absolutely no time for confusion or hesitation. Look at the first step. You must instantly disconnect the oxygen circuit directly from the endotracheal tube. This immediately removes the oxygen oxidizer from the deadly fire triangle. Second, look at the next step. You must rapidly douse the entire airway. You must flood the surgical field with sterile water or saline. This instantly cools the hot tissues and puts out any small burning pieces of material. Third, look at the pull command. You must immediately pull and completely remove the endotracheal tube from the patient. You must also remove all the protective cotton sponges. This physically extracts the burning plastic and the main fuel source out of the body. Finally, look at the last step on the right side. You must immediately perform a rigid bronchoscopy. You must carefully look deep into the lower airways and bronchial tree. You must actively check for any deep thermal burns, melted plastic debris, and severe mucosal injury before doing anything else. Let us close the topic by looking at two major clinical controversies. Look at the left side of your screen. This is the famous margin artifact controversy. Even when you use the absolute best ultra pulse mode, the laser will always create up to 0.3 mm of thermal burn. When the pathologist looks at this under their microscope, these cells are completely carbonized. They will frequently send you a report saying your margins are unevaluable or dangerously close. You must not panic when you read this pathology report. You must never reflexively send your patient for immediate adjuvant radiation just because of this artifact. If you are visually absolutely certain that you had a clear total resection in the operating room, you must simply wait. European guidelines dictate that you simply schedule a second look microlaryngoscopy in 4 to 8 weeks. Now look at the right side of the screen. Some surgeons still loudly argue for traditional cold steel surgery. It is absolutely true that a cold steel knife leaves zero thermal artifact for the pathologist. But a traditional steel knife does not stop the tissue from bleeding. Even a single drop of bleeding is a massive problem in the tiny larynx. To see clearly, you must consistently use a suction tube to clear the blood. This creates a massive physical crowding in your surgical space. Your hands and the suction tube will completely block your narrow view at a working distance of 400 millimeters. The carbon dioxide laser automatically seals small blood vessels up to 0.5 mm in diameters. It strictly guarantees a continuous, perfectly dry surgical field, so you can constantly see what you are doing. This perfect balance of extreme surgical precision and automatic bleeding control is exactly why the CO2 laser remains our absolute gold standard. With this slide, we conclude our discussion on laser biophysics, dosimetry, and hardware. Let us move to next topic of this lecture. Our next topic is ELS Cordectomy classification. We will dive deeply into the actual surgical techniques and the specific classes of cordectomies. Let us start. We will focus entirely on the European Laryngological Society classification of cordectomies. We commonly call this the ELS classification. For young oncology residents, learning this surgical standardization is absolutely non-negotiable. If you do not use a universal surgical language, everything falls apart. Without this standard, comparing clinical trials and reading pathological reports will completely devolve into chaos. Look at this landmark paper. This brilliant classification system was originally proposed by Mark Remakel and his team in year 2000. It was later updated in 2007. This is not just academic nomenclature to memorize for your exams. It is your exact surgical roadmap in the operating room. In traditional open surgery, we simply remove large predefined anatomical compartments. But in transoral laser microsurgery, our approach is totally different. We must carefully tailor our surgical cut perfectly to the tumor's exact depth and surface area. Our strict goal is to preserve every single possible millimeter of healthy tissue. We must do this to give our patient the absolute best possible voice after surgery. So let us look closely at the diagrams on the left side of your screen. We will now break down every single type of these cordectomies step by step. Let us now quickly revise the exact anatomical layers of the vocal cord. To the naked eyes, it looks like a simple band of tissues. But for a laser surgeon, it is a highly complex structure. I want you to think of the vocal cord exactly like a thick electrical cable. If you carefully peel off the outer plastic cover, the cable still works perfectly. But if you accidentally cut the deep copper wire inside, the signal is completely destroyed. Our laser surgery on vocal cords work on this exact same principle. We must strictly understand these distinct layers from outside to the inside. First, look at the outermost surface on your screen. The brown color layer is the squamous epithelium. Just below it lies a very thin basement membrane. Then we reach the lamina propria, which actually has three different layers. The first superficial layer is a jelly-like area, commonly known as Rinke's space. Below that, the intermediate and deep layers. They come together to form a very strong band. Look at the light pink area labeled as the vocal ligament. Finally, at the very deep level, we find the thick vocalis muscle. This deep muscle is the essential copper wire of our electrical cable. Your exact depth of cut into these specific layers will directly determine the European classification of your surgery. Vocal cord tumors are very small tumors. We need to confidently decide how deep the laser resection needs to go to clear the cancer while safely preserving as much healthy vocal cord tissue as possible. Let us look at the various methods for assessing the exact depth of the tumor. There are 5 methods. We do not simply pick one method. Instead, we combine these different modalities. Stage 1 begins in your outpatient clinic. We strictly use video stroboscopy to evaluate the delicate mucosal wave. A perfectly normal wave strongly suggests the disease is strictly superficial. But an absent wave is a major warning for deep infiltration into the lamina propria. Next, look at stage 2. Once the patient is asleep in the operating room, we move to physical tactile assessment. We use simple blunt suction palpation to test the mobility of the lesion. We touch the tumor using the blunt suction tip and try to move it. If the mass feels hard and tethered to the deep structure, you know the invasion goes deeper. 3. We must carefully analyze the vascular patterns using narrow band imaging or NBI. We combine this visual data with our previous wave and palpation tests. If we see absolutely no atypical vascular pattern, we can confidently proceed with a purely superficial resection. Moving to stage 4, we use advanced microscopic tools. We actively use confocal laser endomicroscopy to precisely map the tumor borders. This incredible tool detects hidden cancer cells that look completely normal to the naked eyes. This guarantees that our superficial margins are truly clear. Finally, stage 5. When dealing with bulky tumors, we must get absolute surgical proof of the depth. We achieve this by performing a deliberate transtumoral resection. We must purposefully cut the tumor from the medial side to the lateral side. When your laser finally hits the healthy vocalis muscle, the tissue will suddenly cut perfectly cleanly. This distinct tissue interaction gives you real-time, absolute proof of your exact surgical depth. Let us start with the very first category of resection, type 1 cordectomy. We clinically call this a subepithelial cordectomy. This is our most superficial and most delicate surgical cut. Look closely at what we are actually removing. We strictly remove only the squamous epithelium and the very top layer of the lamina propria. This one. We purposefully leave the deep rinky space, the strong vocal ligament and the vocalis muscle completely untouched. When do we strictly use this exact section in operating room? It is exclusively reserved for very early and highly superficial lesions. This primarily includes severe dysplasia and carcinoma in situ. I want you to remember our strict rule about taking biopsies. You must never use heavy cold steel forceps to simply rip or strip the delicate mucosa. That old stripping technique causes severe permanent scarring and completely ruins the voice. Instead, for early suspected cancer, you must perform this precise type 1 cordectomy as a perfectly clean excisional biopsy. Because we safely preserve all the deep vibratory structures, the functional outcome is truly fantastic. The patient will naturally heal with an excellent voice that is essentially comparable to a completely normal voice. Let us now move deeper to the second category of resection, Type 2 cordectomy. We clinically call this a subligamental cordectomy. Here, our cut goes much deeper than a type 1. We must remove the squamous epithelium, the jelly-like rinky space, and the dense connective tissue of the vocal ligament. See here in these images. Squamous epithelium, the jelly-like rinky's space, and the deep connective tissue of the vocal ligament. But you must pay very close attention to your absolute surgical limit. Your laser must stop exactly at the epimysium. This means you must leave the vocalis muscle completely untouched and strictly intact. See here. The cut is superficial to the muscle. When do we actually perform this deeper cut in the operating room? We use it for early T1A tumors when we suspect the cancer has deeply invaded the ligament. How do you clinically prove that you are really dealing with the T1A tumor during surgery? You must inject sterile saline directly into Rinke's space to lift the tissue up. If the tumor does not lift up and remains physically stuck to the deep tissue, we call this the donut effect. This tethering donut effect is your clear visual signal that the tumor has breached the ligament. Because we safely preserved the thick vocalis muscle, the functional results is still highly favorable. The patient will generally heal with a very good normal to near normal voice. Type 3 cordectomy. It is also called as transmuscular cordectomy. In this procedure, you must remove the mucosa, vocal ligament, and a medial block of the deep vocalis muscle. See here in these images. Medial block of the deep muscle is also cut here. I want you to remember one absolute rule regarding this classification. The exact moment your laser cuts into or removes any fibers of the vocalis muscle, your surgery is immediately classified as type 3. But you must clearly understand the severe functional cost of this deeper cut. Because you are removing the actual muscle bulk, the patient will naturally heal with a concave neocord. This structural change creates a permanent physical gap between the vocal cords when the patient tries to speak. We medically call this aerodynamic glottic incompetence. Aerodynamic glottic incompetence. Because air will continuously escape through his open gap during phonation, the patient will permanently have a breathy and hoarse voice. Therefore, you must strictly reserve this deeper resection only for tumors that have clearly invaded the muscle layer. Let us now examine our most extensive standard section. Look at the diagram on your screen for the type 4 cordectomy. This is also called as total cordectomy. This is an extremely aggressive and radical excision. You must completely remove the entire vocal cord. This includes the mucosa, the ligament, and the entire vocalis muscle. Your absolute surgical limit is the inner pericardium of the thyroid cartilage. You must carefully dissect right down to this cartilage, but you must leave the cartilage itself strictly intact. See in these images. Entire vocalis muscle is cut until the inner perichondrium of the thyroid cartilage. This is the inner perichondrium of the thyroid cartilage. When do we use this aggressive cordectomy? We strictly reserve this for deeply infiltrative T2 tumors or carefully selected early T3 tumors. We use it when the cancer has pushed deep into the lateral paraglottic space. Your primary oncological goal in this type of cordectomy is to completely clear that medial border of the paraglottic space. See here. The contralateral side paraglottic space. In this type of cordectomy, the tumor is excised till that medial border of the paraglottic space. Because you are removing the entire vibratory mass, the entire vocalis muscle, the functional trade-off is very poor in this type of cordectomy. The patient will permanently suffer from a very breathy and weak voice. Therefore, you must only perform a type 4 cordectomy when it is absolutely oncologically necessary to clear the deep disease. Listen to me very carefully now. Let us pause and look at the functional summary of these first 4 standard cordectomies. Look at the table on your screen showing this functional trade-off. This table represents the absolute reality you must explain to your patient before surgery. Look at the strict rule at the very bottom of the slide. Voice preservation is inversely proportional to your oncological depth. The deeper you cut to excise the tumor, the worse the patient's voice will become. Look at the top 2 rows for type 1 and type 2 cordectomy. This orange color is vocalis muscle. Because we safely preserved the thick, deep muscle, the structural result is fantastic. The patient retains an intact mucosal wave or a safely preserved epimysium. This guarantees that the patient will have a normal or near normal voice profile after these 2 types of cordectomies. Now look at the bottom 2 rows for type 3 and type 4. The moment you remove any part of the vocalis muscle, the function drops sharply. See here. In type 3, medial block of vocalis muscle is cut. A type 3 resection creates a permanent concave neocord. This naturally leads to a breathy and hoarse voice. And in type 4, entire vocalis muscle is cut. A type 4 total excision completely destroys the vibratory mass. This will permanently leave the patient with a severely breathy and weak voice. You must always remember that the final concept at the bottom of the screen. The vocal ligament strictly protects the delicate mucosal wave, and the deep vocalis muscle protects the physical mass needed for loud speech. Let us now look at the extended surgical resections. Look at the diagram on your screen showing the type 5 cordectomies. We can call these the escape routes of the tumor. You must strictly use these extended cordectomies when a T1B or T2 tumors breaches the normal anatomical borders of a single vocal fold. Look at the 4 black arrows pointing away from the center of the glottis. These arrows represent the 4 specific directions that the cancer can spread. First, look at the arrow labeled 5A. This is the contralateral extension. This means the tumor crosses the anterior midline to involve a portion of the opposite vocal cord. Next, look at the arrow pointing downward, down and to the right, labeled 5B. This is the posterior extension. This means the cancer has spread posteriorly to involve the arytenoid cartilages. Now look at the arrow pointing up and to the right, labeled 5C. This represents the superior or supraglottic extension. This means the tumor moves upward to involve the ventricle fold, the false vocal cord. Finally, look at the arrow pointing downward, straight down, labeled 5D. This represents the inferior or subglottic extension. This means the cancer is creeping downward into the subglottic region below the vocal cords. We will discuss the specific surgical rules and the severe functional warnings for each of these direct extension in our next few slides. These are the 4 distinct variations of the type 5 extended cordectomy. We must strictly use these extended cuts when the cancer grows beyond the normal borders of one single vocal cord. First, look at the top right diagram labeled type 5A cordectomy. This is the contralateral extension. We use this when the tumor crosses the anterior midline and involves a portion of the opposite vocal cord. See here. Second, look at the type 5B cordectomy. This is the posterior extension. We use this when the cancer grows backwards and encompasses the arytenoid cartilage. See here. Third, look at the type 5C cordectomy. This is the superior or supraglottic extension. We use this when the tumor climbs upward to involve the ventricle fold, which is your false vocal cord. See here. Finally, look at the type 5D cordectomy. This is the inferior or subglottic extension. We strictly use this when the cancer creeps downward below the true vocal cords into the subglottic region. See here. You must always map these exact extensions perfectly before you ever take the patient to the operating room. In our next few slides, we will look at the specific surgical rules and the severe functional warnings for each of these 4 distinct extensions. Let us break down the first 2 extended resections, type 5A and type 5B. Look at the diagram on the left side of your screen. This is the type 5A or contralateral extension. We strictly use this when the tumor crosses the anterior midline. You must carefully resect across the midline to involve a specific portion of the opposite vocal cord. But you must follow one absolute rule during this procedure. Both of the arytenoid cartilages must be strictly preserved. See here. Both the arytenoids are preserved. Now look at the diagram on the right side of your screen. This is the type 5B or posterior extension. We must use this specific type of extended cordectomy when the cancer grows posteriorly to infiltrate the arytenoid cartilage. I must give you a very serious warning about this resection. Removing the arytenoid badly compromises the natural physical closure of the glottis. This will place your patient at an extremely high risk of severe post-operative aspiration. Because they cannot safely protect their airway while swallowing, they can easily develop aspiration pneumonia. Therefore, you must select your patient very carefully and counsel them thoroughly before ever attempting a type 5B procedure. Let us now look at two vertical extensions. Look at the diagram on the left side of your screen. This is the type 5C or supraglottic extension. We strictly use this when the tumor grows upward. In this type of cordectomy, you must completely remove the ventricular fold, which is your false vocal cord. See here. But there is a very important surgical utility for this specific cut. We do not just do it to remove the supraglottic cancer. We frequently perform a type 5C just to achieve an adequate surgical exposure. Removing this false vocal cord gives you a clear visual window to safely dissect the deep lateral paraglottic space below it. Now look at the diagram on the right side of your screen. This is the type D or subglottic extension. You must use this specific type of cordectomy when the cancer has spread downward. It extends below the true vocal cords into the subglottic region. See here. I must give you a very strict clinical warning about this specific extension. Before you ever attempt a type 5D resection, you must demand rigorous pre-operative imaging. You must absolutely rule out any hidden or occult invasion into the cricoid cartilage. If your imaging shows that the cricoid cartilage is invaded, you must stop. Laser surgery is strictly contraindicated and you must refer the patient for radiation or open surgery. Let us look at the final category in the European classification. Look at the diagram on your screen for the type 6 cordectomy. This is also known as anterior commissurectomy. As you can see under the procedure section, this is essentially an endoscopic anterior partial laryngectomy. You must completely remove the anterior half of both true vocal folds along with the commissure itself. See here in these images. But you must look very closely at the danger zone described on your slide. The anterior commissure is a massive anatomical trap. This exact location completely lacks a protective inner perichondrium shield. If a tumor sits here, it has a direct access to involve raw thyroid cartilage. Finally, look at the functional risk on the right side of your screen. When you surgically resect the anterior commissure, your patient faces an exceptionally high risk of severe post-operative glottic webbing. We clinically refer to these thick anterior scars as synechia. This thick web of scar tissue can permanently compromise both their breathing airway and their daily voice. Let us now look at how this European classification guides our choice between the laser and radiotherapy. Look at the thick red dashed line cutting directly across your screen. This line represents a major clinical and functional boundary in early glottic oncology. First, look at the top half of the table. For type 1, type 2 and type 3 cordectomies, transoral laser microsurgery is generally our preferred primary treatment. Because we are safely preserving enough of the deep muscular tissue, the laser offers a fantastic balance. It gives the patient a single-day cure while maintaining a highly acceptable voice. Now look below the red dashed line. If the tumor depth strictly requires a type 4 total cordectomy, any of the type 5 extended resection and type 6 cordectomy, the paradigm completely shifts. In these deeper, highly aggressive tumor, a laser resection will permanently destroy the patient's phonatory apparatus. The patient will be left with a permanent, harsh and severely breathy whisper. Therefore, for these deep structural resections, primary definitive radiotherapy is generally preferred. Radiotherapy allows us to sterilize the deep cancer while safely preserving the mechanical structure of the larynx for a much better functional voice. Let us now look at exactly why the voice changes so drastically after deeper surgeries or type 4 and beyond cordectomies. Look at these two diagrams. They perfectly show how the healing occurs after our laser cuts. First, look at the diagram on the left side. This represents a patient who had a type 1 or type 2 cordectomy. Because we safely preserved the deep vocalis muscle, the structural bulk remains completely intact. When the patient tries to speak, the vocal cords can still firmly press together. This achieves full glottic closure and perfectly preserves the normal aerodynamics of the speech. Now look at the diagram on the right side. This is what happens after a deeper type 3 or type 4 transmuscular cut. Because we excise the structural bulk of the true vocal fold, it heals abnormally. The tissue heals into a permanent bowing shape, which we call a concave neochord. Look closely at the wavy black arrows here. Because of this concave shape, a permanent physical gap remains when the vocal cords try to close. Air continuously escapes through this open gap during phonation. We clinically define this exact mechanism as aerodynamic glottic incompetence. This continuous air escape is the absolute mechanical reason why your patient will suffer from a permanently breathy and raspy voice. With this, we completed our discussion about types of cordectomy. Let us move on to discuss next topic of our lecture. It is margin assessment and pathological dilemmas with TLM. My upcoming slides on this topic will focus heavily on the realities and challenges of achieving clear margins during transoral laser microsurgery. Let us begin. Over the next 12 slides, we will discuss margin assessment in TLM. We will look at the common pathology problems and the reality of micro margins in early glottic cancer. As a laser surgeon, you must know that your job does not end when the surgery is over. Your surgery is truly complete only when your visible findings in the operating room match the final pathology report. Our main goal in this segment of this lecture is very clear. We must learn how to handle the common problem of false positive margins. And most importantly, we must learn how to preserve radiation for future use. You must never waste a patient's future radiation option just because of a pathology report showing laser margin positive. Let us go to the next slide and see the actual size of our surgical margins. Let us look at the massive difference in our surgical margins. In traditional open surgery, we often take a full 1 centimeter margin to guarantee clearance. But if we take a 1 centimeter margin during a laser cordectomy, we will completely destroy the patient's entire phonatory apparatus. Therefore, our standard target for laser is an ultra narrow margin of just 1 to 2 millimeters only. This tiny margin is exactly what maximizes voice preservation. If you are dealing with carcinoma in situ or TIS, the margin is even smaller. We simply perform a complete mucosal peeling. Here, an incredibly narrow margin of just 0.1 millimeter is considered absolutely adequate. Now you might ask, how come such a tiny margin can be oncologically safe? Look at the green box at the bottom of your screen. This is the fundamental anatomical secret of early glottic cancer. The true vocal fold possesses extremely fewer or sparse lymphatic drainage. It has almost no lymphatics compared to the supraglottis and subglottis above and below it. Because of this lack of lymphatic drainage, early glottic cancer is highly forgiving. This unique anatomy is exactly what allows us to safely use these very small margins without compromising the patient's survival. Let us now look at the two enemies we face in laser surgery when we are dealing with margins with TLM surgery. Look at the false positive equation. The CO2 laser is a fantastic tool for precise cutting and stopping bleeding, but it fundamentally alters the cellular architecture at the cut margin. First, look at the middle icon representing coagulation necrosis. Even with the best laser setting, you will always cause 0.1 to 0.3 millimeter of thermal artifact. This intense heat denatures and carbonizes these cells. This makes that specific edge of tissue completely unreadable to your pathologist. Next, look at the icon for formalin shrinkage. The laryngeal mucosa is naturally very dense with water. When you drop this tissue into formalin, it undergoes massive shrinkage. It can easily lose 30 to 40% of its total volume. Now look at the final consequence. Imagine you took a perfectly safe 2 millimeter margin in the operating room. By the time it reaches the microscope, it shrinks to a tiny fraction of charred artifact. This physical illusion is exact reason why we see such a high rate of false positive margins in laser surgery. Let us now look at what happens immediately after we remove the tumor. Because of the tight space in the larynx, we often cannot remove a large bulky tumor in one single piece. We must frequently perform a transtumoral or piecemeal excision. But this completely destroys the standard spatial resolution for your pathologist. Therefore, you must strictly follow the 3 rules of meticulous specimen handling shown on your screen. First, look at step 1. The exact moment you remove a tiny tissue fragment, you must physically flatten it and pin it down. We typically secure these tiny pieces on a simple cork board or a paraffin block. Next, look at step 2 and the picture labeled image A. You must meticulously color code the distinct edges of your specimen. You use different colored histological inks to clearly paint the anterior, posterior and deep lateral margins. Finally, look at step 3. You must accurately map these fragments for the laboratory. You must never send a specimen jar simply labeled as piece number 3. This is completely useless information for your pathologist. You must actively label it with precise anatomical locations such as the deep lateral paraglottic margin. Following these strict steps guarantees that your pathologist can give you an accurate and reliable final margins report. How to map our resection margin for TLM? Look at the slide as an example showing visual reality of the operating room. This is a 0-degree endoscopic view. This shows a clinical T1A squamous cell carcinoma located on the left true vocal cord. Before we begin our type 3 cordectomy, we must clearly map our surgical boundaries. First, locate the star symbol marking the exact position of the anterior commissure here. Next, look at the black arrow pointing downward to the expected posterior tip of our specimen here. Now look at the straight red line cutting directly across the center of the tumor, this one. This red line represents where we will make our deliberate transtumoral transection. As we discussed earlier, we must cut from medial side to the lateral side to visually evaluate the exact depth of the tumor infiltration. Once we confirm that depth, we can safely trace our final peripheral margins. Look at the orange color line on the outer edge, this one. This deliberately marks our lateral or cranial surgical margins. Finally, look at the yellow contour line below it. This yellow line represents our medial or caudal surgical margins. You will notice this yellow line is only partially visible because the margins extend slightly down into the subglottic region. Mentally mapping these exact lines before you ever fire the laser is the absolute key to a safe oncological clearance. Let us look at the practical reality of removing a large tumor. Look at this image. When you have a bulky tumor like this, you cannot safely remove it in one single piece. If you try to pull it out in one large block, you will completely lose visualization of your deep margins. Therefore, we must deliberately cut straight through the center of the tumor. We clinically call this a transtumoral or piecemeal resection. But this safe surgical technique creates a major problem for your pathologist. It completely destroys the normal spatial orientation of the tissue. Now look at the image on the right side of your screen. This shows exactly how we solve this orientation problem in the operating room. The exact moment you remove a small tissue fragment, you must handle it meticulously. You must physically flatten the tiny specimen and securely pin it down. We typically use a simple cork board or a paraffin block to hold it in place. If you do not pin the tissue immediately, the muscle will curl up and the margin will become unreadable. This immediate pinning is the absolute first step in protecting your pathologist. Let us look closely at the physical orientation of our specimen. Look at the image on the left side of your screen. This shows a tiny right vocal cord specimen meticulously pinned down on a cork board. We have used simple syringe needles to keep the tissue perfectly flat. Notice the letter R drawn on the board to clearly indicate the right side. If you do not pin the tissue immediately, the muscle will curl up and the margins will be lost. Now look at the actual pathology report for this exact specimen. Read the frozen section diagnosis. Labeled Cordectomy. Right vocal cord, sent for frozen section. Features are suggestive of moderately differentiated squamous cell carcinoma. All inked margins are free of tumor. Look carefully at the specific warning at the end of that section. However, base is 1 mm away from tumor. Because of this ultra narrow margins, the pathologist specifically asked us to wait for the final paraffin section report. This perfectly highlights a major clinical problem in laser surgery. Frozen sections are very difficult to read accurately because of the laser heat damage and tissue freezing distortions. Finally, look at the bottom section showing the final microscopic examination. The permanent paraffin section safely confirms that all margins, including the separate deep margin, are absolutely free of tumor. This final permanent report is the ultimate proof that your surgical resection was completely safe. Let us now discuss a major controversy with regard to frozen section in TLM surgery. Look at the balance scale on your screen representing the frozen section debate. In traditional open surgical oncology, frozen sections are the absolute gold standard to guarantee clear margins. But in transoral laser surgery, we face these three distinct problems. First, our laser biopsies are incredibly tiny. Second, the CO2 laser inherently causes a thermal charring artifact right on the cut edge. Third, the physical freezing process badly distorts this already delicate and burned cellular architecture. Because of this massive double distortion, it is very difficult for any pathologist to read these margins accurately. Therefore, please look at the distinct consensus rule in the box at the bottom. You must avoid making definitive surgical decisions based solely on a single frozen section. Instead, you must rely heavily on your high magnification visual assessment of the tissue planes in the operating room. You must then safely wait for the permanent paraffin section for your absolute final confirmation. However, look at the bright blue box on the right side for the one strict exception. You may use a frozen section to help counsel an anxious patient immediately after surgery. but you can only do this safely if you have an elite head and neck pathologist sitting in your laboratory. They must perfectly understand laser-induced tissue changes and be able to confidently read through the thermal artifacts. If your hospital does not have this highly specialized pathology expertise, you must abandon the frozen section entirely. Let us now look at how we clinically define and manage the final margin status. First, look at the negative or R0 margin. This means the invasive cancer is completely absent from the thermal edge. For these patients, you simply proceed with standard routine surveillance. Next, look at close margin. This means the tumor is strictly less than 1 mm away from the thermal artifact. For this, we must do high frequency endoscopic surveillance. You almost never need extra adjuvant radiotherapy unless you were visually uncertain during the surgery. Now look at the unevaluable or RX margin. Here, the margin is completely unreadable because of severe laser heat damage or crush artifacts. You must never automatically send these patients for radiation. Instead, you must strictly mandate a second look microlaryngoscopy. Finally, look at the red box on the bottom right. This is a true positive margin or R1. The cancer unequivocally touches the inked surgical margin. Here, you must also schedule a second look procedure for a targeted re-resection. You should only refer the patient for definitive radiotherapy if a safe surgical re-resection is anatomically impossible. Let us now discuss one of the most stressful situations you will face as a laser surgeon. Look at the large red warning sign here. This represents the temptation to immediately send your patient for radiation when the pathology report looks bad. But look at the statistics. Because of the thermal artifacts and tissue shrinkage we just discussed, the reported rate of positive margins after TLM is notoriously high. It can easily range from 20 to 40%. When you receive one of these positive reports, look at the strict clinical directive on your screen. You must not reflexively panic. If your high magnification visual assessment in the operating room confirmed a clean cut straight into a healthy muscle, you must trust your surgical eyes. You must absolutely not escalate this patient to salvage radiotherapy based solely on a thermally altered or unreadable pathology report. Remember our core objective from the beginning of this module. We must always protect the patient's radiation for a true and proven recurrence for future. Instead of radiation, we use a very specific surgical protocol to safely verify if there is any disease left. Let us now look at exactly how we safely handle a positive margin report without automatically using radiation. Look at the clear timeline for the second look protocol. At week 0, you complete your primary laser surgery. Time period between week 4 to 12 is specific waiting period of the healing window. During this time, all the acute swelling and thick fibrinous eschar will naturally slough off. The surgical bed will then safely cover itself in healthy granulation tissue. This clean and stable bed finally allows us to make a perfectly accurate evaluation. So on your target date, you bring the patient back to the operating room. You perform a targeted microlaryngoscopy and safely cut out a very narrow strip of tissue exactly at the suspect site. Now look at the large statistic on the bottom right of your screen. In up to 70% of these second look procedures, the new biopsy comes back completely negative for cancer. This proves that your primary surgery was perfectly curative and the first pathology report was simply a false positive. Finally, look at a critical surgical pearl. During your very first surgery, you must repeatedly use continuously wet neuropatties. You must meticulously wipe away all the black carbon particles and charring from the cut edge. If you leave that black char behind, it will create excessive granulation tissue that looks exactly like a cancer recurrence. Let us now talk about a very dangerous myth in laser surgery. It is called vaporization myth. For many years, some surgeons taught a wrong concept. They said that the carbon dioxide laser automatically burns away an invisible half millimeter of tissue. They claimed that this tissue just turns into smoke and acts as a hidden safety net. You must never fall into this trap. Teaching our young residents that they have a guaranteed invisible safety zone will simply make them careless. You can never rely on this idea of vaporized tissue. It is not a substitute for a truly negative pathology report. If your margins are not clearly negative, you must be absolutely sure there is no cancer left. You must safely do this by bringing the patient back for a second look biopsy. You must do this before you ever declare that the patient is cured. Let us now summarize the three most important rules from this segment of our lecture. First, you must always anticipate the physical reality of the laser. You must absolutely expect a 0.1 to 0.3 mm thermal artifact along with a massive 30 to 40% tissue shrinkage. Second, you must physically protect your pathologist. You must strictly do this by flawlessly pinning, color inking, and mapping your piecemeal fragments. Third, you must boldly defend your surgical technique. You must safely do this by using the second look protocol between 4 to 12 weeks. Finally, you must never blindly sacrifice a patient's radiation bank safely solely on a thermally altered margin report. Following these three strict rules will make you a truly safe and effective laser surgeon. With this slide, we conclude our discussion on margin assessment and pathological dilemmas in TLM surgery. Let us move on to next topic of our presentation. Next topic is about barriers to TLM. In our next 9 slides, we will deeply explore why this excellent surgery is not available to every patient across the country. We will also look at barriers we face in the operating room. Let us begin. We have already seen the excellent survival and voice outcomes of laser surgery. But we must face a very practical reality. This excellent surgery is simply not possible for every single patient. There are three major barriers that often limit our ability to use the laser. First, there are major training barriers. Laser surgery has a notoriously long learning curve. It requires extreme technical expertise and highly expensive hospital setup cost. Because of this lack of availability and expertise, many patients are simply offered radiation therapy instead. Second, there are physical anatomical barriers limiting good laryngeal exposure. If we cannot get adequate laryngeal exposure with our rigid laryngoscope, we cannot safely operate. Third, there are tumor-specific barriers. Lesions involving anterior commissure or showing massive deep muscle infiltration make laser resection highly difficult and risky. Fourth is how to deal with resection margin. We have dealt with it in previous slides. You must learn how to properly identify these specific barriers in your clinical practice. You must know exactly when to say no to laser. Let us go to the next slide and look at the most common problem, which is difficult laryngeal exposure. This is a major barrier to laser surgery. I call it learning curve paradox. In traditional open neck surgery, teaching a young resident is very straightforward. The senior surgeon and the resident can both easily see the exact same surgical field. The senior surgeon can safely guide the resident and immediately take control if necessary. But in transoral laser microsurgery, this teaching dynamics is completely reversed. During the operation, the resident is looking directly through the surgical microscope. This means the resident actually has a much better and clearer view of the surgical field than the senior surgeon standing next to them. Because the senior surgeon cannot see the microscopic tissue planes perfectly, it becomes incredibly difficult to safely teach and control the operation. This specific paradox makes the learning curve for laser surgery notoriously long and steep. It requires extensive dedicated training. And this is a major reason why this excellent surgery is not widely available in every hospital. To safely overcome these training barriers, we are increasingly relying on specialized anatomical larynx models. We must use these models to train our oncology residents thoroughly before they ever operate on a real patient. Let us now look at how we safely overcome difficult laryngeal exposure in the operating room. When we first insert our rigid scope, between 1.5% and 24% of our cases will initially lack adequate glottic exposure. But we do not simply give up and abandon the laser procedure. Instead, we use a strict escalation protocol of surgical maneuvers shown in the funnel diagram. Level 1 is applying simple external counter pressure directly on the patient's neck. We utilize this very basic maneuver in nearly 66% of our cases. If that is still not enough, we move down to level 2, which is partial vestibulectomy. This means we deliberately, safely excise a portion of the false vocal cord so we can clearly see the true vocal cord below it. We rely on this specific technique in about 57% of our difficult cases. Finally, level 3 is a complete or total vestibulectomy. We only need to use this more aggressive maneuver in 4.2% of cases. By strictly following this step-by-step escalation pathway, we can successfully achieve adequate exposure in 95.3% of all our patients. Only a tiny fraction of 4.7% will ultimately fail this endoscopic approach. For these rare failures, we must safely convert this surgery to a traditional open partial laryngectomy or refer for radiotherapy. Let us now move to second major barrier we face. It is how we deal with the anterior commissure involvement. If a tumor reaches this specific area, it becomes much harder to treat safely with the laser. Because of the very tight anatomy and the Broyles ligament here, cancer cells can easily hide and spread into the deeper thyroid cartilage. The involvement of this region unfortunately decreases our local control, a laryngeal preservation and disease-specific survival. But we must carefully look at exactly how the tumor is spreading. Look at the axis of extension. If the tumor spreads strictly sideways along the vocal cords, we call it horizontal extension. This generally has a standard risk profile and is much safer to manage with the laser. However, if the tumor spreads up and down, we call it vertical extension. This is a major surgical warning sign. Vertical extension is a very poor prognostic factor because it frequently means the cancer has aggressively invaded the pre-epiglottic or subglottic spaces. For these vertical tumors, you should generally avoid primary laser surgery. Now look at a very important clinical caveat. Even though our local control rates drop when the commissure is involved, the overall survival for these patients actually remains very similar to patients without commissure involvement. But this is only true under one strict condition. The patient must be managed by a highly experienced surgical team. If you do not have extensive experience with laser surgery in this difficult anatomical area, you should strongly consider radiotherapy for these patients. This is the final barrier we face in laser surgery. Managing suspected positive margins. We already know that the heat from the laser causes severe thermal damage to tissue edges. This heat effect makes it incredibly difficult for our pathologist to evaluate the true margins accurately. Because of this, we frequently receive pathology reports showing suspected positive margins. When you face this stressful situation, you have three distinct clinical pathways to choose from. Pathway 1. This is an immediate action pathway where you quickly perform a second laser resection or transition the patient to radiotherapy. Pathway 2. This is the delayed assessment pathway supported by the 2014 ELS guidelines. Here, you safely wait for 6 to 8 weeks after the primary surgery. You then perform a second endoscopic evaluation to determine if another surgical intervention is truly necessary. Finally, pathway 3. This is the active surveillance pathway. You do not automatically operate or radiate again. Instead, you monitor the patient very closely in your outpatient clinic. You must pay strict attention to any new voice quality impairment. You must also use routine laryngo-video stroboscopy to carefully watch for any real tumor progression. Choosing the right pathway requires excellent clinical judgment and a very reliable patient. We must ask ourselves a very important clinical question. Does a positive margin report in TLM surgery automatically mean a worse survival outcome for our patient? This is a very large study from the National Cancer Database published in 2019. It looked at 747 patients treated with laser surgery for early glottic cancer. They found that 80% of these patients had strictly negative margins. 20% of the patient had positive margins. Was there any difference in survival between the two groups? The result was a highly unexpected. The 5-year overall survival rate was statistically equal between both groups. Having a positive margin did not negatively impact the patient's ultimate survival. It also did not lower their chance of keeping their larynx. But this statistical equality is only true under one absolute condition. These patients must be closely managed and followed by a highly experienced surgical team. Let us now bring together everything we have learned about the barriers to laser surgery. We have thoroughly discussed 3 major clinical challenges. These are exposure barriers, commissure anatomy, and the margin pathology. Notice how all 3 of these blue lines point directly into one single gold box. That box represents surgical expertise. When you are sitting in a tumor board, you must choose between laser surgery and radiotherapy. The deciding factor in that room must always be the true institutional experience of your surgical team. Why experience dictates efficacy? Laser surgery definitely presents distinct mechanical and pathological barriers. But a patient's survival outcome is always stabilized when the surgical team has extreme technical mastery. First, a master surgeon safely bypasses exposure limitations by using learned vestibulectomy maneuvers. Second, they successfully mitigate anterior commissure risk by perfectly understanding vertical extension. Third, they safely manage margin uncertainty by relying on strict active surveillance paradigm. If your hospital does not have this elite level of surgical expertise, you must safely choose radiation therapy for your patient. Let us now look at the specific reasons why laser surgery might ultimately fail. These are some important factors which predict that your TLM will fail. The very first factor is difficult laryngeal exposure. If you cannot clearly see the entire tumor through your rigid scope, you simply cannot cut it out safely. The second major factor is anterior commissure involvement. As we discussed earlier, this tight anatomical area allows cancer cells to easily hide and spread. Next, you must be very careful with posterior paraglottic involvement and arytenoid cartilage invasion. When the cancer goes deep into this specific posterior structure, it becomes highly challenging to remove it completely without causing severe voice and swallowing damage. The fifth factor is a history of previous microlaryngoscopy or prior vocal cord surgery. Previous surgeries create severe scarring, which completely destroys your normal tissue planes. Finally, the last factor is a positive surgical margin, whether it is a deep or superficial. If your final pathology report shows cancer directly at the cut edge, your patient is obviously at a much higher risk of recurrence. You must carefully check for all these high risk factors in your clinic before you even take a patient to operating room. With this, we finish our topic on barriers to TLM. We have already clearly seen that transoral laser surgery is an excellent tool, but it is not meant for every single patient. You must always deeply respect the physical limitations of this procedure. You must routinely use tools like the laryngoscope in your clinic to predict difficult air anatomy. You must be highly cautious with vertical tumor extension at the anterior commissure. And most importantly, you must honestly evaluate the true surgical expertise of your own hospital team. You must never push the limits of the laser if it risks a terrible functional outcome for your patient. If the surgical barriers are simply too high, you must confidently guide your patient towards primary radiotherapy instead. This now brings us to the next topic of our TLM surgery: post-op care and surveillance. Once we have successfully safely navigated these barriers and completed the laser resection, how do we do post-op care and surveillance for these patients? We will discuss important practical issues like voice rest, swallowing evaluation, and how to closely monitor your patients in the clinic. Let us begin. How do we optimize the functional survival pathway after your laser surgery? The successful removal of tumor is only the first half of your job. How you carefully manage the patient after the surgery is equally important. There are three main issues we will look into while following up these patients. First, we will cover airway and somatic recovery. This means we will deeply discuss how to manage the patient's breathing, pain, and diet immediately after the operation. Second, we will discuss functional voice restoration. We will look at exactly how the vocal cord heals and the specific steps we take to give the patient good voice again. Finally, we will explore NBI surveillance and the radiation bank. This is the most critical part of long-term cancer control. You must closely monitor these patients using special tools like narrowband imaging. This helps you catch very early cancer recurrences before they become dangerous. By managing the patient this way, you can safely protect the radiation bank for the future. Let us now move to the next slide and look at the immediate airway management. Let us begin by looking at how we safely manage the patient's airway immediately after the laser surgery. First, look at the very clear baseline rule. We practically never perform a tracheostomy for early T1 and T2 glottic resections. Avoiding a surgical airway hole in the neck is one of our primary goals when we choose this procedure. If you think a patient's airway is so bad that they need a pre-operative tracheostomy, you should strongly consider radiation therapy instead. Now please look at the syringe icon on the bottom left of your screen. Our standard perioperative medications protocol is very simple and effective. We give the patient a single intravenous dose of 8 mg of dexamethasone. We strictly do this for two very specific clinical reasons, shown in the boxes on the right. First, this steroid safely minimizes the acute thermal swelling caused by the heat of the laser. Second, it strongly helps to prevent any dangerous vocal cord spasm right after we remove the breathing tube. We closely watch the patient's airway for first 24 hours to ensure they are breathing perfectly. Let us now talk about the physical pain a patient feels after surgery. When we remove a tumor from the vocal cord, patients naturally are expected to have a terrible throat pain. But there is a major clinical misconception. The internal larynx itself rarely causes severe pain after an isolated laser resection. Instead, the real pain comes entirely from the intense mechanical pressure of our heavy metal rigid scope. We have to push the scope very hard against the patient's tongue and the floor of mouth to get a clear view of the tumor. This extreme pressure frequently causes small micro tears at the base of tongue. It can also temporarily crush the nearby nerves, which we call a focal neuropraxia. Because of this specific nerve pressure, patients might complain of tongue numbness or strange changes in their taste for a few months. You must actively counsel your patient about this specific pain before the surgery happens. If they wake up with a numb tongue, they will be terrified unless you have explicitly warned them first. Unfortunately, you can easily manage this exposure-related discomfort using standard non-opioid pain medications. Let us now look at how the extent of our surgery directly dictates the patient's recovery. First, look at types 1 and 2, which are purely superficial cordectomies. Here, the deep vocalis muscle is perfectly preserved. Because this muscle is completely intact, the patient's swallowing is rarely affected. These patients can safely start a normal diet on the very same day of surgery. They are usually safely discharged as a simple daycare case or after a single night in the hospital. Next, look at the deep and extended resections, which are type 3 and 4. In these cases, a significant amount of structural tissue bulk is surgically removed. You must be much more careful with these patients. You must strictly perform a formal inpatient swallowing evaluation on post-operative day 1. You must reliably do this before you ever allow them to drink or eat normally. Finally, look at type 5B resections on the far right. This specific surgery involves removing the arytenoid cartilage. This creates a highly dangerous functional situation for your patient. By removing the arytenoid, you have essentially destroyed the posterior glottic bulkhead. This creates a very high risk of immediate microaspiration into the lungs. Therefore, you must strictly mandate a thick fluid or semi-solid diet for these patients. You must stay on this highly modified diet until their laryngeal closure naturally compensates and heals. Let us now talk about how we safely manage the patient's voice after this surgery. In the past, we used to tell our patient not to speak at all for up to 2 weeks. We now know that staying completely quiet for too long is actually bad. Total silence stops normal tissue movement. This allows thick scars to form. This leaves the patient with a stiff vocal cord and a very poor voice. Look at our modern relative rest plan. Today, we recommend resting the voice for a much shorter time, usually just 3 to 5 days. During this time, we want the patient to use gentle, easy speech. This early gentle movement is very important. It stops the new healing tissue from sticking to the deep muscles. However, you must give your patient very strict rules. They must absolutely avoid shouting, singing, and clearing their throat. Most importantly, you must strongly warn them never to whisper. Whispering is very dangerous after laser surgery. Whispering causes the throat muscles to squeeze too hard. This badly damages the healing surgical areas. Sometimes we do a complex surgery where we need a delicate piece of tissue to sit perfectly still. In those rare cases, we might still ask for total silence. But for standard laser surgery, early gentle speech is the absolute best way to get a healthy voice back. Let us now discuss a hidden danger after surgery. When we use the laser, it leaves a raw, open wound in the throat. If the patient has acid reflux from their stomach, this acid will wash directly over that healing wound. This is called laryngopharyngeal reflux. This acid is incredibly harmful to the new tissue. It badly delays the normal mucosal healing process. More importantly, it causes highly vascular contact granulomas to form very quickly near the vocal process. This creates a terrifying clinical situation. These bulky granulomas project into the airway and look exactly like an exophytic cancer recurrence. They will cause high anxiety for the patient and often lead to unnecessarily stressful biopsies. To stop this from happening, we must strictly prescribe high-dose proton pump inhibitors. The patient must take these proton pump inhibitors for a minimum of 3 months. This simple medicine protects the surgical bed from chemical irritation. It safely prevents these granulomas and saves you from a false positive scar. Let us now look at the functional outcomes and how we truly evaluate the patient's voice. First, look at the expected outcomes for the superficial surgeries, type 1 and 2. Because the deep muscle is preserved, the delicate mucosal wave usually recovers very well over 3 to 6 months. These patients generally achieve an excellent near normal voice. Now look at the deeper resections, which are type 3, 4 and 5. Here we remove significant tissue bulk, which leaves a scooped out or concave neocord. This missing tissue causes aerodynamic glottic incompetence, meaning air leaks out when they try to speak. Therefore, these patients will have a permanently breathy or raspy voice. Next, look at the sound wave with the large red X through it. You must completely change how you evaluate these post-operative voices. Traditional objective acoustic measurements like jitter and shimmer are no longer reliable. They will always show badly degraded numbers because you have surgically altered the native mucosal wave. Finally, look at the checklist icon on the bottom right. This is your absolute gold standard for clinical evaluation. You must routinely use the Voice Handicap Index or VHI. This simple questionnaire reliably measures the true physical, functional, and emotional impact of the hoarseness on the patient's actual daily life. Let us now look at how we actually fix a weak voice after a deep laser surgery. This is the voice restoration escalation ladder. When we perform deep resections, we leave a concave gap that causes aerodynamic glottic incompetence. This simply means air constantly leaks out when the patient tries to speak. To fix this lost soft tissue bulk and restore glottic closure, we use a step-by-step approach. We start with temporary laryngeal fillers like hyaluronic acid. We can easily inject this in the clinic under local anesthesia. This immediately pushes the resected cord to the middle to quickly improve the patient's voice. In next step, for a medium-term solution, we perform an autologous fat injection. We carefully harvest the patient's own fat using gentle low-pressure liposuction. We inject this fat directly into the paraglottic space to bulk up the concave neocord. We deliberately inject a slight excess of fat because we know some of it will naturally absorb over time. Next step is the permanent surgical solution called a type 1 medialization thyroplasty. This specific procedure requires a traditional open neck incision. We cut a small external window directly into the thyroid cartilage. Through this window, we place a permanent implant like Celastic or Gore-Tex. This implant physically pushes the scarred, stiff vocal cord permanently to the midline. But you must be extremely careful and patient before you decide to perform this final permanent step. There is a very important safety rule regarding that final permanent step. There is an oncological constraint in thyroplasty. There should be at least 6 to 12 months absolute mandatory waiting period. If you want to perform an open type 1 medialization thyroplasty, you must strictly wait at least 6 to 12 months after the initial laser surgery. What is the rationale for this waiting period? We know that most early local tumor recurrences will happen within this first year. You must definitely prove that the surgical bed is completely clear of cancer first. If you immediately put a permanent silicone or Gore-Tex implant into the neck and the cancer comes back underneath it, you have created a surgical disaster. The permanent foreign body will completely hide the early recurrence from your routine endoscopic examination. Therefore, you must patiently use temporary fillers in the clinic until this high-risk time window has safely passed. Let us now discuss exactly how we monitor these patients carefully in the clinic. Here we are going to look at the clinical value of narrowband imaging. This is a highly advanced optical tool. When a patient comes for their routine follow-up, you must not rely on standard white light alone. NBI safely filters white light down to two very specific wavelengths, exactly 415 and 540 nanometers. These precise wavelengths are intensely absorbed by the hemoglobin in the blood. This means the superficial blood vessels will look extremely dark and sharply contrasted against the normal tissue. Now please look at two circular images on your screen. On the left, you see a completely normal healing pattern. Notice how the blood vessels here are perfectly flat, highly regular, and gracefully run parallel to the surface. This is exactly the healthy pattern you would want to see. But now carefully look at the image on the right showing a local recurrence. Here, the vascular pattern is highly abnormal and completely chaotic. You will see tiny punctate dark brown spots clearly scattered across the tissue. These spots represent abnormal perpendicular loops of blood vessels, which we call IPCLs. By actively looking for these highly specific dark spots with your scope, you can safely catch a cancer recurrence at the microvascular level. You will easily find the cancer long before a large dangerous mass ever forms. Let us now review the specific timeline for how often you must examine these patients in your clinic. Our primary goal here is to closely monitor the healing and safely catch any microscopic recurrence early. You must examine the patient very frequently, ideally every 1 to 2 months initially for 1 year. During these visits, you must strictly use high quality endoscopy combined with narrowband imaging and stroboscopy. Next, look at the schedule for year 2. You can safely extend the visits to every 2 to 3 months. Your main clinical task during this second year is very challenging. You must carefully differentiate between harmless healing tissue like a fibrinous eschar or a contact granuloma and dangerous malignant neoangiogenesis. Now look at the timeline for year 3. You will now see patient every 4 to 5 months. Here you are simply evaluating their long-term mucosal stability and the structural symmetry of the vocal cords. For years 4 and 5, you will see the patient every 6 months. You must continue using high magnification endoscopic evaluation to carefully watch for any late local recurrences. Finally, look at the instruction for beyond 5 years on bottom right. Your job as a clinical oncologist is never truly finished. You must enforce annual lifelong surveillance for these patients. This is absolutely necessary because these patients are at high risk for developing second primary tumor in the head and neck region. Let us now look at what happens when our first treatment fails to cure the cancer. Look at scenario A first. This shows the clinical reality when primary radiation therapy fails. Look at the tissue state after radiation. The laryngeal framework becomes permanently fibrotic, hypoxic, and arthritic. This means the native tissue has terrible blood supply and extremely heavy scarring. Because of this severely damaged tissue, trying to perform an endoscopic salvage laser surgery carries vastly higher complication rates. The ultimate outcome in this scenario is very grim. A radiation failure frequently forces a devastating total laryngectomy. This means completely removing the patient's voice box, which leads to lower overall survival and much higher fistula rates. Now look at the scenario B. This shows the clinical reality when a primary laser surgery fails. The tissue state here is completely different and much safer. Your patient's basic anatomy and their radiation bank remain entirely intact. Therefore, your salvage reality is much more forgiving. The patient can easily undergo a second deeper laser procedure without significant morbidity. But what if the recurrence is too large for another endoscopic salvage? You can simply transition the patient to a full curative course of definitive radiotherapy. By choosing laser surgery first, you safely preserve all of your future salvage options. Let us now bring everything together in our final slide for this segment of our lecture. Look at the large gold safe in the middle of your screen. This safe represents your patient's radiation bank. This is the most valuable asset your patient has for their long-term survival. Notice the 3 black arrows pointing directly to this safe. To successfully protect this safe, you must perfectly execute 3 major clinical tasks. First, you must have a meticulous control over their airway and any chemical reflex after surgery. Second, you must provide aggressive voice and swallowing rehabilitation so they can function normally. Third, you must use hypervigilant narrowband imaging surveillance to safely catch any tiny recurrence early. Listen to me very carefully now. Transoral laser microsurgery is much more than just a surgical choice. It is a brilliant radiobiological preservation strategy. By safely choosing the laser first, you keep the patient's radiation bank completely intact for the future. This definitive surgical strategy ultimately gives your patient the highest possible chance of keeping their natural voice box for the rest of their life. This now brings our current topic on post-operative care and surveillance to a close. We have clearly seen exactly how to manage the healing process safely, restore the voice, and accurately secure and protect the patient's future salvage options. Let us move on to our last topic of our presentation. Our next topic is the future of laryngeal oncology. We are going to see what advancements are happening in TLM. We have spent a lot of time discussing the current gold standard of transoral laser microsurgery. But we also honestly know that our current standard has major physical limits. We constantly struggle with difficult patient anatomy and straight line of sight barriers. We also struggle with making perfect margin assessment because of the thermal heat damage. To safely solve these specific clinical problems, our field is rapidly moving towards advanced technologies. In this segment of our lecture, we will explore exactly how these new tools are changing our surgical approach in the operating room. We will discuss the major shift away from the traditional carbon dioxide laser towards new blue light and KTP laser. We will look at how robotic assistance and new flexible laser fibers help us safely cut around tight corners. Finally, we will explore how artificial intelligence and confocal laser endomicroscopy will help us see perfect surgical margins in real time. For decades, the carbon dioxide laser has been our primary surgical tool. This has been the established era. We know this traditional method has major physical limitations. We are strictly limited by a straight line of sight exposure. If the patient has difficult anatomy, we simply cannot see the tumor through our rigid metal scope. Furthermore, the traditional carbon dioxide laser is highly absorbed by water. This causes a significant amount of unavoidable thermal heat damage to delicate vocal cords. Now there seems to be a technological convergence. This represents the exact future of our surgical specialty. Instead of relying on heavy microscopes and rigid scopes, we are shifting to highly advanced technologies. We are now actively exploring alternative laser wavelengths like blue light and green light. These specific lasers can be delivered through thin, highly flexible glass fibers. We are also combining these flexible lasers with robotic assistance. This robotic technology allows us to safely drive the laser around tight corner inside the throat. Finally, we are rapidly integrating advanced optical imaging and artificial intelligence. These specific digital tools will help us see the exact microscopic borders of the cancer in real time. This exciting convergence of technology definitely solves our line of sight problems and vastly improves our overall surgical precision. Let us look at the fundamental difference between our standard and new lasers. Photoablation versus photoangiolysis. On the left side, we have our traditional carbon dioxide laser at exactly 10,600 nanometers. This is a purely ablative cutting tool. Its primary target is the intracellular water inside the tissue. When the energy hits water, it vaporizes the cells and creates a sharp incision. However, it strictly requires a rigid, straight line of sight delivery using a heavy micromanipulator. More importantly, it destroys the delicate vocal cord layers straight down along the deep Z-axis. Therefore, we optimally reserve the carbon dioxide laser for deeper infiltrative T1b and T2 squamous cell carcinoma. Now look at the KTP and blue lasers. These represents a completely different biological mechanisms. The KTP operates at 542 nanometers and the blue laser operates at 445 nanometers. These specific wavelengths completely ignore water and exclusively target oxyhemoglobin inside the blood vessels. Instead of cutting, they cause highly targeted coagulation and photoangiolysis. This specific action safely starves the tumor of blood and causes ischemic necrosis. Because the energy is delivered through a highly flexible glass fiber, we can easily bypass our old rigid line of sight barriers. Most importantly, this energy perfectly spares the underlying collagen framework of the vocal ligament. This is exactly how we safely eradicate the tumor while maximizing the functional voice outcome for our patients. Let us look at exactly what happens inside the tissue when we change our laser wavelength. It is called chromophore shift. Look at the anatomical diagram showing the green laser targeting the highly vascular tumor. Because this new tumor only targets blood, it causes targeted intraluminal thrombosis. This simply means it selectively destroys the feeding blood vessels of the cancer. The cancer cells safely die from a severe lack of blood, which we call ischemic necrosis. Most importantly, carefully look at the healthy tissue underneath the tumor. The laser perfectly spares the delicate extracellular matrix of the lamina propria. This specific technique is absolutely brilliant for bulky exophytic T1A lesions. Because we only melt the superficial tumor away, we never have to cut into deep vocalis muscle. This successfully prevents that permanent scooped out structural concavity we see with standard lasers. By keeping the structural muscle completely intact, these new lasers often provide a significantly better voice outcome than our traditional carbon dioxide surgeries. Let us now talk about a major upgrade to how we actually see the surgical field. This is called a 3D exoscopic surgery. For decades, we have been forced to look through the narrow optical corridor of a heavy traditional microscope. This old method is badly physically demanding for the primary surgeon. Now look at the robotic camera arm shown on the left side of your screen. We are actively replacing those bulky microscopes with sleek robotic articulating arms. These robotic arms send a live video feedback directly to a large 4K 3D stereoscopic monitors inside the operating room. Look at the oncological benefits of this technology. This new digital technology gives us an unparalleled depth of field and an automated zoom function. This specific digital advantage allows us to perform hyper-precise margin analysis much more easier than we could do it before. Finally, look at the democratizing the view. As academic teachers, This is perhaps the most exciting clinical benefit for our surgical training programs. In the past, only the primary surgeon could clearly see the delicate microscopic tissue details. Now every single resident and fellow in the room simply wears this passive polarized glasses. You will all see that exact same high magnification tissue interface simultaneously on the large digital screen. This completely eliminates the isolated optical corridor and vastly improves how we teach this highly complex surgery. Let us now look at a tool that completely changes how we find the edge of the cancer. This is called confocal laser endomicroscopy. This is a highly advanced optical technology. Look at the metallic probe touching the vocal cord on the left side of your screen. This delicate probe acts as a live in vivo optical biopsy. It gives us a real-time image of the living tissue at exactly 1000 times magnification. Now look at the bright green circle in the middle of your screen. This is the exact cellular reality we see during the active operation. We can immediately see hidden cancer cells, atypical mitosis, and a dangerous loss of cellular cohesion. We can clearly see these abnormalities even in tissue that looks completely normal and healthy to our naked eyes. What is the clinical impact of this? As we discussed in the last segment of our lecture, standard frozen sections are highly controversial and often unreliable because of the laser's thermal artifact. This advanced technology safely overcomes this major limitation. We actively use this probe to map the exact microscopic borders of the tumor before we even start cutting. We can also put the probe back on the tissue at the very end of the case to evaluate our peripheral mucosal margins. If this technology shows any abnormal signs, we immediately take a small targeted biopsy from the exact spot. This technology gives us immense clinical confidence that our surgical margins are truly clear. Let us now discuss how we finally solve our biggest physical problem in the operating room. For many years, we eagerly tried to use traditional multi-arm robots for early glottic cancer. Those older robotic systems completely failed in the narrow, tight angles of the glottis. Their rigid arms were simply too big and bulky to fit properly. Worse, they relied on standard electrocautery, which causes massive, unacceptable thermal damage to the delicate vocal cord. Look at the image at the bottom showing the rigid red tube failing to make the turn. This represents our historical line of sight limitation. But now, look carefully at the metallic snake-like instrument gracefully bending around the curve. This represents the exciting new single-port flexible platforms. We can now safely place a single small cannula into the patient's mouth. Through this single port, we deploy highly flexible articulated instruments that easily navigate these difficult anatomical angles. We are now actively integrating thin, highly flexible laser fibers directly into these new robotic arms. This allows us to deliver ultra-precise laser energy deep inside the throat. We can literally achieve microscopic cutting precision around a sharp corner. This incredible technology completely removes the old glottic barrier and allows us to safely operate on tumors we could never reach before. Let us now look at how artificial intelligence is helping us evaluate the tissue during surgery. This is computer-aided narrowband imaging. Earlier, we discussed how we monitor our patient closely for any cancer recurrence. There was this clinical challenge. If a patient has had previous radiation, the laryngeal tissue will often look very red and inflamed. It is highly subjective for a human surgeon to tell the difference between harmless healing tissue and dangerous new cancer blood vessels. We formally call these dangerous new vessels malignant neoangiogenesis. Now look at the AI solution to this. We are now actively using deep learning computer algorithms, specifically called convolutional neural networks or CNN. We teach these digital networks by feeding them millions of video frames of both normal and cancerous laryngeal tissue. Look at the real-time deployment section at the bottom right. During the live operation, this AI system instantly analyzes our endoscope video feed. Now carefully look at the glowing digital map overlaid on the vocal cord on the left side of your screen. The AI actively draws this live probability map directly on our surgical monitor. It highlights exactly where the dangerous atypical blood vessels are hiding. As we discussed earlier, we call these abnormal vessels IPCL. The AI can successfully predict where these cancerous loops are long before our human eyes can even see a mass. This incredible technology completely removes the human guesswork from our surgical evaluations. It guarantees that we can safely catch a local recurrence at the absolute earliest microscopic stage. Let us now look at the ultimate future of surgical precision. It is autonomous laser surgery. Look at the computer chip icon hovering over the active laser beam on the left. We are currently developing artificial intelligence system that actively monitor the tissue while we are cutting. It is like a real-time tissue scanning. These deep learning algorithms constantly analyze the optical reflection and the acoustic sound waves created by the active laser. Look at instant differentiation. This continuous scanning is incredibly important. The computer can instantly tell the difference between burning tumor tissue and healthy vocalis muscle. It knows exactly what the healthy deep muscle looks and sounds like. Finally, look at the text at the bottom right regarding millisecond precision. Human surgeons always have a natural delay in their physical reaction time, but the computer does not have this delay. The artificial intelligence can automatically shut off the laser energy the exact millisecond it reaches the healthy deep margin boundary. This brilliant technology completely removes human error. It safely guarantees a perfect oncological deep margin every single time. Let us now bring all of these new advancements together. We can no longer think of these technologies in isolation. They are now part of a completely integrated and synchronized surgical ecosystem. There are four major technological pillars which perfectly overlap. First, we have our new angiolytic wavelengths like the KTP and blue laser. Second, we have our advanced visualization giving us 1000 times cellular magnification. Third, we have highly flexible robotics to drive this energy around tight corners. Fourth, we have autonomous artificial intelligence to guide our precision. When you perfectly combine these four tools, you achieve our ultimate surgical goal. You achieve maximum oncological control combined with ultimate vocal preservation. This beautiful convergence of technology will completely redefine how we manage early glottic cancer in the future. Let us now bring this long lecture to a close. We have covered a massive amount of clinical information in this lecture. But if you remember nothing else, please remember these core principles. First, Look at precision selection and multidisciplinary triage. Surgical success is always defined in the outpatient clinic, never just in the operating room. You must strictly align your final treatment choice with the patient's personal lifestyle and their specific vocal demands. Next, biophysical mastery and the operator variable. You must constantly balance a definitive oncological cure with the delicate preservation of the vocal ligament. And you must always be completely honest about your own institutional experience and surgical limits. Next, socio-economic value of our surgical approach. A single day laser surgery completely removes the heavy financial and logistical burden of prolonged radiotherapy for your patients. Most importantly, look at the salvage guarantee and strategic preservation. This is the most profound radiobiological strategy of our field. By safely choosing upfront surgery, you strictly protect the patient's future radiation bank. This approach guarantees the absolute highest ultimate organ preservation rate over their entire lifetime. Finally, look at the future standard at the bottom right. The beautiful convergence of new angiolytic lasers, flexible robotics, and artificial intelligence will completely redefine our surgical limits. You must always remember to treat the entire human being sitting in front of you, not just their larynx. Thank you all for your incredible focus and stamina during the extensive lecture. You are now ready to safely apply this surgical principle in the real world. With this, I end my presentation. Thanks for watching. See you next video. Signing off, Parveen Ahlawat.